Okay. Markus, können wir beginnen? Okay, okay. So, good morning, dear colleagues, ladies and gentlemen. I warmly welcome you to our 5th Congress in Germany about WAIOT, held here at the Knappschaft Kliniken Recklinghausen. I thank all of the colleagues who have traveled a long way in long fly to join us for this event. Over the next days, we have interesting topics and presentations on infections in our field of orthopedic and traumatology. Due to the problems and war situation in Ukraine, in Middle East, in the rest of the world, we had some difficulties to get a visa, to find a fly. The German embassy makes many problems. Around 20 to 30 colleagues were registered in our program, but he or they have not the possibility to come to us. The point of the Congress was very difficult this year, but we are very happy about your coming, and I hope we have a successful Congress. As a highlight of our Congress this year, we have a live demonstration of a surgical simulation on Sawbone von Ringfixator Elizarov. I think it's possible to have this show, this simulation, today or tomorrow. Actually, it's programmed for tomorrow, but it's possible that we have enough time today. And we have a skill lab, and in the skill lab, we make the surgery with Professor Osman and Professor Olvan from our staff, and the participants in this room have the possibility to see this simulation. I would also like to sincerely thank the industry for the generous support of a Congress. In the last years, it's very difficult actions on difficult problems to gain some sponsors, companies. But we have a good contact to 3 or 4 big players, and we are happy to support or for their supporting. Infection is a topic that has become extremely important and presents a major problem in our field. Together and through such events, we hope to find better solutions for this problem in coming years. You know, the surgeons, the people, the researchers, and especially the surgeons, the orthopedic surgeon, would present the best cases, lucky people, fantastic surgery results, but anybody would speak about complications and infection. A big researcher said to me, Mr. Tesval, at this moment of the world, we have this situation. We have many antibiotics, it's correct. But due to the problems with the resistance of the bacteria, of the virus, viral problems, and microorganisms, we have some situation like before we have the antibiotics, yes, due Alexander Fleming, because of the resistance. Before we begin the presentations, I would like to give a short presentation about our federal state, and so you know where you are. I wish you a successful conference, and thank you again for your attendance and coming to Germany to our hospital. Because some speakers, dear colleagues, did not receive visa and are absent, their presentations will be replaced by other lectures and by other colleagues. And the lectures are, we have time for it, 10 to 50 minutes is okay. But I think due to panel and this breaks, we can gain more time for interesting discussions. Yes, where we are, so. The state in that we are is the North Rhine-Westphalia, this area. We have states like Berlin, we have states in Hessen, Frankfurt. North Rhine-Westphalia is our state in Germany, and we are in Recklinghausen. Where is Recklinghausen? Recklinghausen, or our state, that is the map of Germany, is in the west side of the country. And the capital of our state is Düsseldorf, and approximately 18 million people live here in this state. It's very compact, and we have many, many hospitals in our state, and that is at this moment a problem because of the very compact situation of the hospitals. The government decides to cancel some departments and some hospitals. 328 hospitals with approximately 120,000 inpatient care in our state. What is the symbol of this area? The symbol is the coal mining. Traditionally, the coal mining, here is the heart of coal mining in Germany. The coal mining, this picture is like a lift, ascensor, and that is the symbol of this state. In this picture, you see it overall. In our state, we have the city Cologne. This is a metropole and one of the most beautiful and famous dome is in Cologne. And when you stay here for 2-3 days, from here to Cologne, we need approximately 60 minutes, 1 hour. It's okay if you visit this monument. And the river Rhine is one of the big rivers and famous big rivers in Europe. And in Bonn is a city, the last capital of Germany. The now is the capital is Berlin, but the capital Bonn is the home of Beethoven. Yeah, the musician Beethoven is born in Bonn. And naturally, soccer. Soccer, here is the heart of soccer in Germany with Schalke, with Duisburg, with Bochum, Düsseldorf, and Borussia Dortmund. Yes. Yeah, first Liga. We are in the map in the area Recklinghausen. Area Recklinghausen has many small cities, but we have a compact hospital and people amount, a number in this area. And we are in the capital of Recklinghausen, the city Recklinghausen. Yeah. That is our hospital, the air photo, Knappschaft Kliniken. The Knappschaft Kliniken is an insurance and has 10 hospitals too, and is in Germany one of the, I think, famous hospital owners and we have rehabilitation centers, acute hospitals, and this hospital, and this room, and this conference room belongs to Knappschaft Kliniken Recklinghausen. We have in 3-4 kilometers from here the second brother house in our unit, and that is in Marl. That is some sentences, some pictures from this area. You have a small imagination, and I thank you again and again for your coming and for your long fly and train and way. And I'm very happy to have you here because at this time we have great problems around the world, but I think we as surgeons, we as researchers have the possibility to change the life and the quality of life. Thank you very much. We begin with the first presentation. The first presentation is our General Secretary, Carlo Romano, Professor Carlo Romano from Milano. On Carlo, bitte. About WAIOT.
Thank you. Thank you, Mohammed. And let me check my presentation. Where is?
We have open the first.
It's open.
Is prepared. Yes.
Is this? No, this is the. This is probably this one. Okay. Is working? Okay, thank you. So, I am Carlo Romano. I'm the General Secretary of WAIOT. And I would like to thank Professor Tesval for organizing this Congress of WAIOT, even in a challenging situation, because as you have heard before, we have many colleagues coming from areas where they had problems with the visa or problems with ongoing conflicts, so they could not attend. But in any case, I think he could overcome many of these challenges, and I really hope this Congress will be fruitful for all of us. In these 5 minutes, I will give you just a short overview of WAIOT. What is this association, the World Association Against Infection in Orthopedics and Trauma? This is a scientific association, no-profit association that was built in nearly 10 years ago now, 9 years ago. We were just 10 people in a room that decided to start this idea, this project. And our idea was to bring together colleagues from different disciplines interested in musculoskeletal infection to increase the knowledge in this challenging field and to support research in the area of bone and joint infections at a worldwide level, cooperating in cooperation with existing institutions and other societies. Our reference society was CICOT since the beginning, and we are affiliated also with CICOT. And our final goal is to raise awareness about the issue of musculoskeletal infection that should not be seen as a complication of surgery, or not only as a complication of surgery, but as a disease that needs our attention and that we can control and mitigate in many cases. The vision of WAIOT, we had since the beginning a scientific and humanitarian targets. The idea was to keep the costs low by using technologies offered today, and even now we are thinking to go to a next step in this direction, but we will probably touch this in the General Assembly today. And this needs a flexible structure with a perspective that is inclusive. We have members from more than 100 countries now, and a open access free to everybody. And for this, it was decided to not apply membership fees and to let open the membership and the possibility to participate to everybody. It's possible to register directly in the website, if you like. This is our website, WAIOT.world. Today we have more than 2,500 members from 115 countries. We are present in the social media. We have a running newsletter every month and a editorial activity. Our interest is in publishing what we call shared papers that see the cooperation of different centers around the world to set guidelines and to push forward the research in the field. Currently, we have an open special issue on antibiotics with very special rates for our members. So if you like, or if you have a research that can fit the title of this special issue, you can refer directly to us and contact WAIOT at waiot.world. We have some collaboration, and WAIOT has issued grants for research and has participated in many meetings or symposia organized around the world in several congresses with important participation in some of them, and is a continuing effort to spread the knowledge and to increase the participation. This is the Congress that was organized by Professor Tesvald here in Recklinghausen 2 years ago. It was like a course. And we often, or nearly every year, also hold a symposium at the CICOT. We have awards to best research and presentation, and we organize every year an annual congress. As you can see here, we started in 2021 during COVID, and we have been in Cairo, we have been in the United States, in Miami, in Florida, last year in Yokohama, in Japan, in a very successful meeting. This year we are in Germany, and next year we are going to be in Argentina, in Buenos Aires. So I thank you, and I invite all of you, if you like, to come to the website to stay updated and to join WAIOT. Thank you.
No, we can change it. hintereinander haben, der Papa, ne? Gestern. Ja, genau, er wollte mehr. So, Mr. Henkel had the presentation, prevention of surgical site infections, and I think I give you the microphone, yes?
Yeah, thank you. No.
Ist unten, ist es richtig? Alles klar, weil das war schon unten offen gewesen.
Ja, ja, ich weiß. Hello, my name is Isabel Henkel. I'm actually from the industry side. But don't worry, I'm a medical doctor as well. What I see in this conference and very... Oh, that is difficult here. Oh God, oh God, oh God. Do it in this way. It's all, yeah, much, much better.
I turn it on when I'm back.
No. Does it work? Perfect. So what I see, and glad to be here, the ladies are a little bit underrepresented. Only 2 I can see here, you have to work on that. Might be the challenge for the next conference to invite a little bit more ladies here. When I started this presentation and asked to do something of prevention and surgical site infection, I thought, everybody knows anything about surgical site infection. It might be a little bit a boring topic or know the stuff there. What I try to do, give you a little bit practical experience, what you can do in your own hospital, what you can do in daily practice, which make a change then. Nonetheless, just to starting a little bit the classification and the definition of surgical site infections. If we talk about surgical site infection, we put it all in one pot. We always say, yeah, it's a surgical site infection. In fact, there's a huge difference. Depends in which area you are. If you are just a superficial one, if you're in the muscle area, or if any organ is involved in that as well. That makes a huge difference from the cost side, from the treatment side, and therefore you should have it in mind. I put in the percentage of that, so only 40%, and that is what we always have in mind. Yeah, surgical site infection, that's only on the top, that we always have in mind, or I at least, during my clinical practice, I always said, a little bit of skin infection, doesn't matter. Only 40% are superficial, and the other 60% could be really critical infection. So thinking about the risk factors, clear, you know this all. If you have the emergency surgery, the risk is higher. If the treatment or the surgery is longer than 2 hours, the risk is higher. If it's an open surgery or an endoscopic surgery, the risk is higher. That is just from the surgery type of the surgery. And then we have the patient risk behind. Typical way, obesity, alcohol, smoking, any other comorbidities in there, having a cancer, immunosystem. So all these, what you more or less have on all other indications as well. So that was a basic part, what I just have a startup and reminder. Coming, and that is especially in the surgery side, we always think about a little bit surgical site infection. Anybody else can manage that. You can do it on the ward, and we don't see it that much critical as it is. nearly now all the countries worldwide, they have a kind of surveillance system. Not all of them are that good in reporting as the German one, but we try to collect data worldwide. The WHO is working on that. They try to get data on surgical site infections all over the world. Coming here from the National Reference Center, there are some orthopedic surgeries included in that. There are just a few indications. They follow up and report. But these orthopedic surgery are in. And if you see about that, the infection rate based from the simple arthroscopic surgery in the knee with lower than 1% coming up to a revision surgery and hip replacement coming to 3%, which is a lot. So 3% every third patient. Now you can see, okay, how many do you do in your hospital? And it could be, if you are a smaller hospital and you only have 50 hip replacements or revision replacement, that you never see surgical site infection there. And then you see, doesn't matter, it's not relevant for me. Nonetheless, the numbers are pretty high. You can follow up this data from your own country. Most of the country, they have a reporting system that you have to collect the data for surgical site infection, and you will see country by country. Germany is relatively good in this data, so the data, the infection rate are relatively low. Some other countries are higher. Why is that interesting? And mostly you see, yeah, come on, surgical site infection, you give a little bit of antibiotics and fine, it's done and doesn't cost anything. In fact, it costs much more than you think about. That are recent data from a publication from November 2025. Clearly, and they made a systematic literature review with 36 papers which were included here. And the average cost is 24,300 euro. So it's a huge number, and you think about that, just one single patient in every, in average, roughly 25,000 euros for an indication. It's worth to think about what can we do to prevent surgical site infections. Yeah, now coming in a completely different area, and not what I think what you expected now, because what I would like to do, give you a little bit practical experience. What can you do in your own hospital? What can you do? And that is mostly the problem you have in your hospital. You have any hospital manager, you say, oh, all too expensive, save the money, we don't have the money for doing something. Now the question is, how can you convince your own hospital manager? How can you convince your government? How do you get the payment for whatever you like to do? Or what you have in the research area, they are called gaining clinical evidence. Everybody asked for evidence. And what you see at the end, you get a bunch of case reports, and then the government says, oh, sorry, on case reports, we don't pay anything. It's just, you have to provide proper evidence. Doing a clinical trial, an RCT, in an area like surgical site infection, it's relatively difficult because the group of patients are relatively heterogeneous in there, so it's not so simple. But what you can do is generating real-world evidence. If you do it in a proper way, the government, they accept real-world evidence worldwide now, so it's not only a case for some governments, they do this. And the question is, what options do you have to do? I listed here the typical real-world evidence collection data, so it starts with a clinical audit. If you see, the evidence level is relatively low with a 5, but it has nonetheless a huge impact in there. You can have the registry studies, so that is something what I I personally always like to build up a registry with surgical site infection or which indication you have, just to gain the data in the right level of evidence. So and coming back to these lowest level of evidence level 5, with a clinical audit, it might be that you say, oh yeah, it's the same like a case report. In fact, it's not, because you can make a huge change in your own hospital. So what is actually a clinical audit? There are lots of guidelines existing what can you do with a clinical audit, and then just an example here now for surgical site infections. So you start with any hypothesis. You have an idea in mind what you like to do within your hospital to change anything. So that is a first step. You identify the area where you would like to make a research. Then you set the criteria. You analyze with your team together to say, okay, that's what we are doing today, and that what we like to do in the future, or that is a change we would like to do. Then you collect all the data. It doesn't have to be a super long time. It's a question, when can it be relevant in the data? Then you analyze the data, of course, and if you see there's a better clinical outcome in the data with a new procedure, with a change you make, you implement it in your hospital, and then you can start to reanalyze and see if there anything else. If you do this collection of data in a proper way, it is a super convincing factor for your hospital manager, and also for the government, because the government worldwide, they accept this data. Now you say, what can I do? Just to give you a pretty simple example how it could look like. That is an example from Spain, what they did. Same principle. We are thinking about having clinical guidelines. I personally, yes, I worked more than 15 years in a hospital. If the people ask me how many guidelines did you read during the time, if I have to be honest, not a lot, yeah, because you always have something, you don't have to have time to read 100 pages. That is not what you like to do. You would like to have it in a simple way. It's the same with your nurses on the ward. What can you do? You need, and it sounds a little bit simple, but you need a one-pager. You need something like this, which is a simple pathway, which translate the guideline, what you have, in simple words where it's always clear what to do. What the Spanish guy did here, and what you see here quite clearly, if you go back to the first slide, with the risk factors, they implemented that. They have the ASA classification in, they have the body mass index in, there's a risk factor. They simplify that all. And then they made a pathway based on their hospital, on their protocol, to say, okay, that could be a simple pathway, follow that, and then you make progress in that. Just having, and yes, I'm from the industry side, giving, and I have to have anything to explain it a little bit. So what SAT is doing, the company I'm working for, we have a Sorbach technology. Our concept is binding bacteria and not killing them. The benefit of binding bacteria is that you don't have any risk for antimicrobial resistance, you don't have any endotoxin expression what you have, and so something more, so that is a concept just to have it in. Oops. And now I would like to close and go back a little bit to this concept. What can we do? How can we collaborate? What can we do in the future? And what we always say, it's a joint approach. It's not only one hospital can reach anything. We have to work together. And there are lots of elements where we have to work with the government as well. There are lots of countries, they are working with the hospital together with the government. Just let you give me an international example. Indonesia, where a good collaboration with the Ministry of Health from Indonesia. Do you know, and that is quite interesting, when I started the work with Indonesia, I was super surprised you can buy antibiotics over the counter there. You don't need any prescription for antibiotics. And then I followed up, there are some more countries, they just get it anywhere. And how can you manage that in any way? And then I went with, in Indonesia to the healthcare market. It's like a market, like a Turkish bazaar, where you can buy everything you like. Yeah, and the antibiotics are in the sunshine, and I was fully shocked. I had to make some pictures out of that because I couldn't believe. From the area we are here in Germany, for example, lots of other European countries as well, I always think, yeah, you have a pharmacy there, it's under control, temperature control, and an end, but not in all countries on the world. So, and therefore, coming with these, in this joint approach together, making a collaboration with the government, it's super, super important if you would like to make a change in prevention of surgical site infection. One is the data collection. We talked about what can you do with the data collection. So I had this example from the National Reference Center in Germany, gave you an example of what can you do to get real-world evidence from your hospital site. What can we do with, and do we have an algorithm? So that what I showed with the pathway, can we have this as an international pathway or a national pathway? Could it be a little bit more than only your hospital? You have it in your hand. How can we create awareness? Of course, that is always, and that is what me personally annoys a little bit. We are talking about surgical site infection. The first word, what you hear, awareness, awareness, awareness. Yes, it's correct, but does that make really a change? We are talking about awareness since millions of years, and you only have to see in the WHO and go 20 years back, awareness. And now, so we have to do it in a different way. We have to take it in our hands, take responsibility for that, and make a change in there. Focusing on AMR, that is what we heard about there as well, is a topic as well. And your government, wherever you are in the world, they should make any change in their legislation. And that is possible. So, for example, I mentioned Indonesia. They changed their legislation based on all this information and work. So that is what you can do. And now it's up to you to have your own ideas, being a little bit creative in that, what you want to do, and have fun. Thank you.
Thank you, Mr. Henkel. Thank you very much. I think it's better to discuss at the end of the session, and we can continue with the next presentation. Please, I change just a little the places of the presentations. It's just a little surprise. Professor Alizadeh from Baku speak about infection after osteosynthesis or arthroplasty based on a new model of etiology and pathogenesis of acute hematogenous osteomyelitis. Professor Alizadeh from Baku. Cengiz, here.
Thank you.
Your presentation. Yine du musst ein bisschen helfen. Das war 14 Uhr gewesen.
14 Uhr.
Er tauscht das
Einmal close.
Diese.
14. Thank you very much. First of all, I will say that it's a very good Congress. Thank you very much, Professor Tezval Mohammed. Thank you. Dear moderators and colleagues, our topic today is attempt to better understand the cause of infection complication after arthroplasty and osteosynthesis. Two of the most common precision in trauma and orthopedic surgery. I would like to begin this presentation with these timeless words of Omar Khayyam as a reminder that what we now consider important and correct may, with the passage of time, turn out to have been only a very early and imperfect understanding. Unfortunately, the incidence of infection after fracture fixation has not substantially decreased in recent years. Developing new antibiotics and modifying antibiotic protocols alone has not solved this problem. The data show that microorganisms are involved not only in early postoperative infection, but may also reach the fixation site hematogenally at a later stage, drive chronic low-grade inflammation, and contribute to bone destruction, non-union, and implant failure a long time after precision. Here we see the mean rates of clinically apparent infection after primary hip arthroplasty, and the proportion of presumed aseptic revisions in which intraoperative culture revealed occult periprosthetic infection, usually around 10 to 15%. Is most registered show the reported incidence of PGI after primary hip and knee arthroplasty is about 1%. However, if the revisions planned as aseptic, a cold infection is found in routinely 10 or 15 of cases. This indicates that the true burden of infection is higher than suggested by primary precision data alone. If we summarize the general infection data after arthroplasty, we obtain the data you see in the table. Based on our 40 years experience, including 34 years heading the region's first specialist musculoskeletal infection department and more than 8,000 operations, I have reached a clear conclusion. In infection, basically the sequence of events that take place the same and match our model of acute hematogenous osteomyelitis. Surgical or systemic stress first induced marrow and soft tissue necrosis, and only then follows bacterial colonization of this necrotic foci. Let's look at when the first signs of acute hematogenous osteomyelitis appear on radiographs, and then compare this time with the first signs of infection after osteosynthesis. This day about 2 weeks. And time to the first radiographic signs of osteomyelitis after osteosynthesis is similar, about 2 weeks. In acute hematogenous osteomyelitis after osteosynthesis, infection following joint arthroplasty, the predominant pathogens are same, Staphylococcus aureus. The radiographic onset is also similar, typical appearing at about 2 weeks. Together, these observations strongly support a common etiologic pathway rather than 3 unrelated disease procedures. Dear colleagues, If we try to answer this question, we will come close to understanding the most fundamental mechanism behind PGI and FRI. And most common of this is, why do microorganisms leave the comfortable environment of the colon to migrate to foreign body surface and begin colonizing them? Why? This is our new model of etiological pathogenesis of acute hematogenous osteomyelitis. In our view, is an ideal model to study what happened in the body in the very early stages of infection. In our stress-based concept, we distinguish three phases: imbalance between free radicals and antioxidants, cell necrosis with aseptic inflammation and microbial translocation, and finally, this third stage is finally classical inflammation with microcirculatory valvular and tissue damage, and so on, so on. Based on this, we hypothesize that acute hematogenous osteomyelitis, which occurs exclusively via the hematogenous route, can serve as a model for understanding PGI and FRI. In context to classical theories, we propose that the process begins with stress-induced necrosis of bone marrow and bone cells at the subcellular level, before microorganisms become involved. This is etiology scheme that we built to infections after osteosynthesis and arthroplasty. We have taken the liberty of depicting the development of infection after arthroplasty at osteosynthesis in an allogeneic stress three-phase pattern to acute hematogenous osteomyelitis, applying the same sequence of stress, tissue necrosis, and subsequent microbial colonization. The first phase of infection development. Let us look to the situation patients face before arthroplasty or osteosynthesis that may predispose to infection: pain, fear of surgery, and other factors that can be summarized as psycho-emotional stress. The key question is what is stress? At least it is basic parameters. And how does it affect the organism? This is increased blood flow, activation of lipid peroxidation process, then depletion of antioxidant system, stress-related change in the colon. These processes are universal and occur in all warm-blooded organisms. When the body's buffering system are exhausted, physiological adaptation may fail and pathological process can develop. Free radicals are continually produced in cell as a byproduct of energy metabolism. Under normal conditions, their levels remain controlled because they are neutralized by the cellular antioxidant system. Severe or prolonged stress increase free radicals production, developing antioxidant systems. This results in an imbalance between free radicals and antioxidants. These highly reactive components begin to damage the lipid membranes of mitochondria, microsomes, and cells, lipid peroxidation process, leading to cell death. The cell contacts are released into the environment, which ultimately damage surrounding cells and tissue, and cell necrosis take on the appearance of an uncontrolled chain reaction. Let us look at the second phase on inflammation. If we measure therapy in the first hours and days after surgery, we usually see high value. And the more traumatic the procedure, the higher the therapy. But at this stage, it's still mainly a reaction to an aseptic process. To cell necrosis, on many cases, the body can cope with this on its own. Necrotic cells are cleared by apoptosis, phagocytosis, and other mechanism. However, another scenario is also possible. A surgical wound can become contaminated through exogenous and endogenous pathways. The exogenous route has been studied for more than a century. But we still know relatively little about the endogenous road, which is why the questions we raised at the beginning of this work remain highly relevant. Change of the colonic wall that occur during stress have been described, including dilatation of the macrovasculars, replacement of lactobacilli and bifidobacteria at the mucosal surface by opportunistic bacteria. Penetration of these organisms through the vascular pores, followed by translocation into the necrotic bone zone. In these studies, we see indicated that translocation of microorganisms from the colon to necrotic areas is part of a broader physiological interaction between the host and the microbiota. These processes do not always proceed smoothly. Disruption of normal control over translocation can facilitate massive entry of opportunic bacteria into necrotic zone. These bacteria may inhibit by apoptosis, and during phagocytosis, macrophages themselves can become as a Trojan horse for bacterial spread in this way. Different pathogens can exploit phagocytosis to evade the innate immunity and disseminate with this host. Biofilm formation. After about 5 to 7 days, the biofilm is considered fully mature and stable, with maximal resistance. Many bacteria enter a persistent state, and treatment becomes much more difficult. Interestingly, it is in routine the same time window that acute hematogenous osteomyelitis is transformed into the chronic form. At the beginning of the third phase, that is early PGI or FRI, the process can often be interrupted by necrotomy, coupled in irrigation, antiseptics, or local or systemic antibiotics as part of a dire strategy. However, once a mature biofilm has formed and a clean reaction of reinfection is established, eradication is usually very difficult without removal of the hardware. Dear friends, this way of looking at etiology and pathogenesis invites us to rethink infection prevention not only in terms of microbes and antibiotics, but also in terms of stress necrosis and the complex physiology of the holobiont. This approach may seem a bit unusual, and that would be a fair reaction. It clearly requires new research and proper clinical trials. But perhaps this is exactly the direction we need to explore. Thank you very much.
Thank you, dear Cengiz. Dear colleagues, let us continue with Professor Romano. Carlo, you speak about one-stage management of periprosthetic knee infections with antibacterial coating, long-term results.
I think it's this one. Yes. Okay. Mm-hmm. Schön. Na, forse è questo, no? No. We have to remove this one. This. It's blocked. Blocked. Okay. So, in this presentation, we will report an experience about the one-stage management of periprosthetic knee infection with the use of a resorbable antibacterial coating, our long-term results. These are my disclosures. Nearly 10 years ago, we published a systematic review about the efficacy of one stage compared to two stage in the hip. According to our results, it was not possible to show a difference in the results of one stage compared to two stage. And also, we showed that one stage cementless, on the average, provides the same results as one stage cemented. In the same year, Hunutsor and colleagues from UK published a similar study in the knee, showing that one stage and two stage, on the average, at similar follow-up, do provide similar results. This has been further confirmed by other studies, more recent studies, but when comparing, when only including comparative studies, studies that only include a series treated with one stage and two stage, according to this review, two stage is shown to be superior. But in this study, they only include papers from 2000 to 2023. If we look at more recent data, with the nearly 5,000 patients included and 21 studies, only comparative studies, one stage to two stage, once again, the difference is negligible, or one stage seems to provide better results. This is another paper published last year that gives the same results. In 2018, we reported an experience in two centers. A first experience with the use of a resorbable antibacterial coating in the treatment of periprosthetic infections with a one-stage procedure compared to two-stage treatment. And our results, the results of this two-center study, at a minimum 2 years follow-up, show that one stage, once again, is equal or even better than two stage. So the aim of our study of today is to compare a single center experience, a retrospective study, at very long-term results. Patients were treated with a single-stage procedure using hybrid prosthesis. The cement, antibiotic-loaded cement, was applied only in the metaphyseal part of the prosthesis, and the DAC coating was applied in the diaphyseal part and in the modular part of the implant. The hydrogel, which is based on is a hyaluronic and polylactic acid hydrogel, was loaded with 1 or 2 antibiotics. This is a retrospective study. Patients were included, treated from 2014 to 2023. We had a cohort of 52 patients. 48 were septic knee prosthesis and 4 were infected spacers, knee spacers. 4 patients are lost to follow-up. Host type, the majority of patients were type B or C, nearly 75%. These are the comorbidities that we found. These are the results. On the average, the treatment was performed on infection lasting for years. Nearly half of the patients had previous revision surgeries. Duration of surgery, around 2 hours. Systemic antibiotics were administered on the average for 1 month. And this is the microbiology. As you can see here, we have a proportion of 27 patients with negative results. And 12, around 13% of our patients had a mixed flora. This is a case, infection with sequestra, Streptococcus alpha hemolyticus. At the time of surgery, the preparation of the coating, the application and the implant with the coating applied also on the modular surface. The result, here we are 28 months later, the clinical aspect. This is a patient with rheumatoid arthritis, MRSE, 73 years old, several surgeries before. The reimplantation using a hinge prosthesis. We use this hinge prosthesis as an uncemented implant, except in the epiphyseal part where we put antibiotic cement. This is another patient, mixed flora. The clinical aspect at the time of surgery and the results. This is another patient, knee instability, MRSE, the reimplantation, the clinical aspect. Diabetes, smoker, MRSA. I go quick because the cases are similar. And the clinical result. This is another case. She got a prosthesis, then she had a rupture of the patellar tendon. She got an infection. This is the bone scan showing an uptake, especially at the femoral condyle site. It should be, this is the surgery, just to show that, of course, for the success of one stage, it is important the debridement, as we all know, and the removal of all the implant, the cement, if present. And in this case, the use of imaging technique can be helpful. In fact, we found behind the prosthesis this bone loss in the femoral condyle, exactly where it was shown by the bone scan. And here you must remove all the biofilm and the membrane, as it is done here, until you find the living bone. Here is the preparation of the hydrogel, which is prepared. It takes around 3 minutes to prepare the hydrogel, which can be mixed with the antibiotics of your choice, and the application to the implant that is then applied in the usual way. And the same is done at the femur. In these cases, in which you start from nearly primary implants, it is possible for this patient to walk the same day or the day after with a fast track that is very similar to a primary implant. Streptococcus mitis was isolated in this particular patient. So the results overall, they are under publication. We had 48 patients available for review, and we had 97.9 no infection recurrence. We had one case with infection recurrence that I will show you in a minute, at a mean follow-up of 7 years. with 4 patients lost to follow-up. This is the case, the failed case. This is a female, 78 years old. She came to our observation, and we isolate an MRSE. She had a 2 times failed spacer, and we treated this patient in 2015, and she got an implant with a DAC added with vancomycin on the basis of the preoperative isolate. And it is not working, I think. No, no, not the pointer, but I think it's not going on.
Was soll ich machen? Hier?
Huh?
You can see it.
Yes,
Is
I
it
can
okay?
see, but
Okay.
it doesn't proceed the...
Aber wir kommen nicht weiter. Geht nicht weiter, oder? Geht nicht weiter, also diese hier. Komm einmal aus.
But it goes? Yeah, but it does not go on, it goes on my screen, but not on this screen. You see, it goes on the computer, but not, it's not, so you see? No, it doesn't change. It doesn't change the point.
Also hier geht's, aber überträgt nicht, meinte er. Kommt es jetzt?
Okay, bye. No.
Yes.
It does not update the... Moment. we can start to do some discussion
You can,
on
you
the
can,
first.
yes, you can moderate it. I have to.
Yes.
Good morning. You have seen the 70% you don't find any germ.
No.
You
Not in 70%.
no, 27. You remember the research from CTAC in CICOT in Madrid? He got one of the germs was Cutibacterium in the endocrine Hamburg. Yeah. We doesn't search for that.
Exactly.
No, we don't know that it's in the hip and normally it's in the shoulder.
Yes, but in our experience, we did not, in this series of patients, we did not find the Propionibacterium acnes in the knee. It is less common, but maybe it can be something that was the pathogen in these cases with negative results. It's possible, yes. Yes.
In the mechanical aspect, you see any difference between the implant of stent without cement and the use of hydrogel?
Mm-hmm, mm-hmm. Yes, but I used this hybrid configuration for this kind of prosthesis. Is possible to use as a hybrid prosthesis with only cement in the epiphyseal part. This is good in case of re-revision because you don't need to remove all the cement. This is, for example, the endo model that I showed. This is a titanium stem, which is designed to be used cementless, while in the epiphyseal part. So this is the design of the prosthesis allows to be used as a hybrid prosthesis. So it works. Okay, so in this particular patient, this was the result. But the patient, a few months later, she went to another hospital with this condition. She sent to me a picture, and they found she suffered for recurrent dermohypodermitis, erysipelas. She had a chronic urinary tract infection and recurrent colitis. And when she came in this condition, in this hospital, they decided to do an amputation, something that probably we would not have done in this case because it was possible to make a re-revision again. In any case, this is the failed case that we have included. In conclusion, this is the longest DAC coating retrospective study about one-stage knee prosthesis revision. It appears a safe procedure, and the hydrogel can be used in a hybrid system. And we had quite good results at long-term follow-up. Thank you for your attention.
So, the colleague for our colleague Fadel is absent, and the colleagues of Professor Fadel, Professor Shaukat Ghazal from Egypt, speak about philosophy of one-stage diabetic foot management. Mr. Ghazal.
Here, lecture.
Excuse me. So, vorne 0.
Ich sehe ihn gerade nicht.
Das ist diese hier.
Da, der.
Diesen, genau.
Okay. Where is next and the back? Here, where is next and the back? Warte mal, mach hier oben. Yes, okay, from the start.
Yes. Mhm.
Okay. Hast du schon gedrückt?
Nee, noch nicht. Hier müssen Presentation. Hier.
Hello, everyone. First of all, I would like to thank Dr. Tetzvel and my dear Professor Dr. Fadil for their invitation in the 5th WAIOT Congress. My name is Shaukat Ghazal Hafiz, orthopedic consultant for orthopedic surgery in National Institute of Neuromuscular System in Cairo, Egypt. I would like to, this talk is talk of my Professor Dr. Fadil, but for some problems in his visa, he couldn't come, and I will speak the talk instead of him. My talk, I will talk about one stage in diabetic foot surgery. We all know the big problem in that meet the orthopedic surgeon is infection, is a nightmare. Infection plus diabetic foot, double nightmare. Today we will talk about how to manage infection in diabetic foot all in one stage, in one surgery only. Infected diabetic foot, philosophy of surgery. What is the right philosophy is to prevent good diagnosis or early diagnosis of Charcot arthropathy is the right thing we do, but misdiagnosis of the Charcot arthropathy, misdiagnosed mostly of the cases I meet in diabetic foot, misdiagnosed as a cellulitis. And when it managed like this, it will go for a deformity and ulcers, and the end is amputation. So the right philosophy is to prevent from the start and good diagnosis. Late philosophy, when there is deformity or ulcer, is to manage, don't wait other opinion. Orthopedic surgeon in diabetic foot is the leader, not a vascular or plastic or medical surgeon. You are the leader in diabetic foot management. This photo in the right, there's plantar foot ulcer. Mostly we see in most of 70 or 80% in our case in Egypt. And this is the nightmare of all orthopedic surgeons in our Egypt, in our country. So, I would like to present this case, midfoot, plantar ulcer, rocker bottom deformity with equinus. Most of cases of diabetic foot is midfoot, is the common than hindfoot Charcot. It was to consult microsurgery and plastic and wound care, but don't wait their opinion and take a decision to prevent amputation, and mortality rate is very high in above knee amputation. In our cases, it may be above 50% of our patients. Charcot arthropathy may be either acute or chronic. I prefer classification, classify the Charcot or diabetic foot. Is it acute or is it chronic? There are different management between the two stages. But sometimes there's two stages may be combined in the same foot. Hind foot, chronic or healed stage, mid foot, acute stage, and we must deal with two stages at the same time. Osteomyelitis, ulceration, chronic Charcot, acute Charcot. History, there is 38 years old male, type 1 diabetes with midfoot ulcer. The ulcer, when the patient came to us, the ulcer was more than 60 months, and the foot deformity was more than 2 years. Multiple surgery was done for the patient by general surgeons. Rocker bottom deformity 2 years ago, continuous walking, result slowly, plantar ulceration. Several debridement by general surgeon, some fragments get out during examination, frequent dressing, debridement, ulcer more than 6 months. Finally, ulcerated area become infected. There is, I convinced that infection, superficial infection and deep infection, even in diabetic foot, like surgical site infection, superficial and deep. Again, in the diabetic foot, superficial or localized infection, or deep or diffuse and aggressive infection. So the problem increased. Deformity, ulcer, infection, nightmare increase. Investigation done for the patient. Laboratory studies. Radiology, we must do X-ray and CT to planning the arches of the foot, and how to reconstruct the foot to be plantigrade tripod foot. The patient walking on a point, central point in the plantar foot, and this is the main problem and the cause of the plantar foot ulcer. So we study the X-ray and CT well to reconstruct the foot and restore the medial, lateral, and transverse arch to gain tripod stance or plantigrade foot reconstructed. There is many classification, pathological and anatomical. Pathological classification, I use to use the major classification: acute or active Charcot, and chronic or healed Charcot, and anatomical hind foot, mid foot, or forefoot. This is the shape of the foot of our case. There is many fragmentation. Here we see the cuboid. The patient, all his weight on the cuboid bone only. And this is the high pressure point. So the result is ulcer, then infection, then amputation, if you don't plan or interfere. This is a CT. Okay. X-ray show loss of midfoot tarsal bone architecture and malalignment or forming plantar mass. Laboratory investigation show hemoglobin A1C 8. We do our surgery 8 or 9. We can't wait till the hemoglobin A1C to be controlled more than this. CBC, SARS, reactive serum albumin not conclusive. Duplex ultrasound was normal. He stopped smoking pre-operative according to our advice. Problem, how to analyze the patient. Charcot midfoot, large plantar foot ulcer, and the deformity. You can see the equinus and the infection. Don't waste time with the patient. Treatment of Charcot arthropathy depend on many factors, include clinical stage, is it active or healed Charcot, location involvement, is it hind foot or midfoot. Most of cases we meet is midfoot Charcot, but surgical management is very, very low in midfoot Charcot, but hind foot less common, but many surgery done for hind foot Charcot. Degree of the deformity and the patient comorbidities. Treatment consists of two phases. Acute phase management include immobilization reduction as a general management of Charcot foot when you meet. Post-acute phase treatment surgery, usually reserved for chronic case with joint instability or severe deformity. There is first line of treatment, non-operative treatment, total contact cast, non-wood bearing, controlling of the betas, and general comorbidities of the patient to avoid the deformity of the foot and ulcer and infection. It's our goal in the start. Late, when the patient comes to us with a deformity and ulcer, non-operative treatment has no role in this case, as it will complicate it and go for amputation. And this is our goal to prevent. Treatment of Charcot arthropathy, mainly non-operative, the main treatment of loading, total contact cast, prefabricated brace, Charcot restrained orthotics, anti-resorptive drugs, electric bone simulators. Surgical method. Our goal in this case, first of all, we must treat infection or osteomyelitis, first of all, then realign the foot biomechanics to do surgical offloading to the ulcer to give the soft tissue and skin to heal. And fixation, good fixation to prevent recurrence of instability and ulceration again. Fixation, we use internal fixation according to the infection, internal, external fixation, or external fixation only. Technique. First step in our surgery, we do tendo-Achilles lengthening. In most of cases, we do gastrocnemius to avoid overlength to tendo-Achilles, as it will complicate with heel ulcer as a calcanean gait. So we do gastrocnemius incision, debridement of the ulcer, and exostectomy of the most of part of the cuboid. Osteotomy to regain the talo-first metatarsal angle, Mears angle, and realign the medial transverse lateral arch, and do the fusion, subtalar and foot fusion, and fixation with beaming, the ideal in this case, not plating, combined with external fixation to control the rotational instability. This is a photo. This is the left, the normal foot arch. The right, our case, calcanean pitch angle, nearly zero, Mears angle restored, distorted, and the foot arch or bis planus. This is our stability, our shape. We see clinical, the patient, the medial arch was elevated and restored. And this is our fixator, circular fixator, gastrocnemius incision, debridement, osteotomies. This is the clinical photo in the image, intraoperative. All we see the arch. We see here the arch is restored, calcanean pitch angle restored, talo-first metatarsal angle restored, and fixed first by screws or being. Double compression screw now we use all in our patients. Then we apply the external fixator Elizarov. This is the shape, clinical shape of the leg after intraoperative. We extend the fixation high in the tibia. This will give stability of the foot. Stability means soft tissue healing. Any soft tissue problem, infection in the foot must be stabilized. Even if you don't want to do fixation or fusion, just stabilize the foot. It will heal. Infection will subside. This is X-ray. This is the shape of the foot after 1 month. Elizarov gives us a chance to don't put a slab or cast, so we can handle with wound care without problem daily. Just surgical fluid, tendo-Achilles lengthening, restoring the arch of the foot. The ulcer will completely healed after 1 month only. This is the shape of the foot after removal of the external fixator. We leave the screws because of many patients complain of delayed union or non-union. These screws give us stability for 1 or 2 years for complete fusion. We extend the fusion to subtalar to prevent stress on the subtalar joint and charcot or instability in the subtalar joint. This is the shape of the foot after removing Elizarov, complete healing of the ulcer, plantigrade foot, complete restored the arches of the foot. No part of the foot is amputated. All the fingers are present. After these 6 weeks in cast of flooding, this is 1 year post-operative. 1 year. This patient, after 2 years or 3 years, I don't remember, he's stopped suddenly the treatment of diabetes and enter in complication of the foot, but not in this foot, in the other normal foot, in the other foot, and did mid-foot amputation because of gangrene, come to us with gangrene and severe infection. But the foot we did, the pathology improved with osteotomy. Most of our patients after osteotomy, fusion, drilling, sensation have been regenerated, vascularity improved. So the pathology, when the pathology is improved, the recurrence will decrease. We are all team orthopedic surgeon, microvascular, plastic, wound care, but you are the leader in diabetic foot. Lazaroff ring fixator is available method for preserving the affected foot in patient with Charcot arthropathy. Correction of the foot and ankle deformity, maintenance of correction, stability, alignment is the goal. Attempt bony fibrous fusion. It's our goal to do fusion, but it's okay if it is fibrous, the patient is okay with this. And give some mobility, not stiff foot, rigid, and this will decrease the recurrence of the ulcer. Lazaroff ring fixators will enable early weight bearing, offloading, care of soft tissue, prevention of skin ulceration, and avoidance of amputation. Charcot foot and ankle all in one option. Thank you.
Thank you very much, Dr. Osman. The next speaker is our colleague from Dortmund, Dr. Schottes, and speaks about bone reconstructions of septic bone defects. He wishes to have the lecture in German, but the slides is in English. Yeah? Thank you very much, Dr. Schottes.
Welcher ist denn das jetzt?
Das ist eine von 9:15 Uhr.
Berichte über unsere Strategien zum Erhalt von Extremitäten. Es stellt sich für uns immer die Frage, ob derartige Verletzungen überhaupt zum Erhalt einer Extremität führen können. Die Probleme, die uns hierbei umgeben, sind vielfältig. Es ist zum einen der große Knochendefekt, es sind die Veränderungen der Weichteile, vorausgegangene Operationen. Wir haben Patienten mit bis zu 30, 35 vorangegangene Eingriffe. Und es ist die chronische Osteomyelitis. Zudem kommen die Komorbiditäten, die Patienten mitbringen, und die Motivation für eine sehr lange Behandlung hinzu. Hier in Bildern die Herausforderung, die wir haben: chronische Infektionen, wo Fisteln angelegt worden sind. Es sind die großen Defekte hier bei Plattenosteosynthese mit einem Spacer. Es sind die Weichteile nach zahlreichen Operationen und die Instabilität. Wir stellen vor, ein Kollektiv von 32 Patienten mit einem Durchschnittsalter von 46 Jahren und einem Längenaufbau des Knochens bis zu 21 Zentimetern. Die Gründe hierfür sind führend durch Verkehrsunfälle zu sehen. Es sind Kriegseinwirkungen mittlerweile bei 25% unserer Patienten. Die Privatunfälle machen 25% ebenfalls aus und die Arbeitsunfälle sind überraschenderweise auf dem Rückzug. Wir haben hier einmal dargestellt unsere Defekte, durchschnittlich 66 mm, der kleinste bei etwa 22 und der längste mit 210 mm an der Tibia, hier ein Ausheilungsbild. Dieser Patient läuft heute mittlerweile ohne Hilfsmittel. Wir haben zu beachten die Verletzungen mit 43% offenen Verletzungen bei Aufnahme in unser Krankenhaus, 37% geschlossen und 18% haben Fisteln, also lange chronische Verläufe. Zusätzlich haben wir eine erhebliche Anzahl von Paresen mit insgesamt 43% unserer Patienten, bei denen entweder ein Nerv oder auch mehrere Nerven betroffen sind. Der Infektionsstatus ist eine besondere Herausforderung. Wir haben immerhin bei etwa 77% der Patienten Infektionen, entweder Fluoride oder klinisch erkennbare Infekte, bei denen wir die Keime nicht mehr finden aufgrund von Vorbehandlungen. Wir haben aber auch eine ganze Reihe Infekte, die saniert sind oder Patienten, bei denen wir den Infekt weder am Knochen noch in der Bakteriologie finden. Haben wir aber Keime, sind sie häufig multiresistent und wir haben 56% unserer Patienten mit Problemkeimen, die eben multiresistent sind. 43% sind Keime, die in dieser Richtung keine Probleme machen. Unser Behandlungsalgorithmus sieht so aus, wir machen zunächst die Infektionseradikation, denn dieses bildet die Grundlage für die knöcherne Rekonstruktion. Meistens oder nahezu immer verwenden wir eine temporäre Stabilisation unter Einlage eines Spacers in den Defekt, um eine Maskerlemmembran zu erzeugen. Dieses hat sich als günstig erwiesen. Zeitgleich kümmern wir uns um die Weichteile mit einer plastischen Rekonstruktion, denn dieses bildet die Grundlage für eine stabile, vitale Bedeckung des knöchernen Defektes. Hier können wir zurückgreifen auf die Kollegen der plastischen Chirurgie, die wir in unserer Abteilung haben. Von erheblicher Bedeutung sind auch bestehende Nervenläsionen, also Paresen, die häufig Arthrodesen erzwingen, die wir in das primäre Konzept einbinden müssen. Als erstes kommt die Eradikation des Infektes hier an einem Situs bereits mit Einlage eines Spacers, der mit einem lokalen Antibiotikum, manchmal auch mit einer Mischung von mehreren Antibiotika beladen ist. Wir erzeugen damit diese Maskerlemmembran und wir halten uns die Option offen, möglicherweise in einem Zweiteingriff Nachresektionen durchzuführen. Wir machen simultane Bedeckungen von Geweben durch freie oder auch lokale Lappenplastiken, wenn diese eben erforderlich sind. Bevor wir eine Knochenrekonstruktion machen, und hierauf fokussiere ich ja, müssen wir uns mehrere Fragen stellen. Erstens, funktioniert ein intrameduläres Verfahren durch einen Nagel? Brauchen wir eine 3D-Rekonstruktion bei verspätet zu uns kommenden Infekten und Fehlstellungen? Und sind Rekonstruktionen mit einer operativen Maßnahme möglich? Und die Defektlänge hat ebenfalls Einfluss, wenn man Nägel verwenden möchte. Für den Nagel sprechen für uns die proximalen und distalen Enden der betroffenen Knochen mit etwa 5 cm, weil man diese Nägel dann ordentlich verriegeln kann. Defekte von 8 bis 10 cm Länge lassen sich mit Nägeln noch versorgen, wenn man sogenannte Pitstops einplant. Es sollten, wenn es geht, keine weiteren Resektionen erforderlich sein, weil das um einen Nagel herum schwieriger ist und, wie gesagt, Achskorrekturen, wenn es geht, mit einer Operation zu erledigen sein. Für den externen Fixateur sprechen kleine periphere Fragmente, wenn wir die einfach mit den Nägeln unten nicht mehr vernünftig verriegeln können. Folgeeingriffe, die wir planen und 3D-Korrekturen bei Defekten, die wir dann besser über einen Hexapoden aufstellen können, aber auch Kontrakturen an angrenzenden Gelenken. Ich habe hier einige Beispiele mitgebracht, die wir mit den unterschiedlichen Möglichkeiten bearbeitet haben. Hier einen Ringfixateur, bei dem wir zunächst den Defekt mit einem Spacer aufgefüllt haben, dann eine vorübergehende Stabilisierung, in diesem Fall mit einem Hoffmann-Fixateur. Später sind wir für die Korrektur des knöchernen Defektes auf den Elisarow-Fixateur umgestiegen und haben trotz zahlreicher Voroperationen diesen Defekt durch primäre Naht verschließen können. Bei diesem Patient haben wir dann eine distale Osteotomie durchgeführt und einen retrograden Transport durchgeführt. Hier zum Beginn, dort auf der rechten Seite, zum Ende im Rahmen des Dockings. Der Kallus ist hier noch sehr zart zu sehen, hat sich im weiteren Verlauf entwickelt. Kompliziert war dieser Vorgang durch ein nutritives Problem des Patienten, der aufgrund einer posttraumatischen Belastungsstörung keine ausreichende Ernährung mehr zu sich gezogen hat und deshalb eine Kallusinsuffizienz gebildet hat. Wir haben dann nach dem Docking eine Weile gewartet und haben später additiv diesen Nagel eingebaut. Hier sieht man auch, dass sich der Kallus mittlerweile weiterentwickelt hat. Der Patient läuft heute weitgehend ohne Unterstützung durch Gehhilfen. Hier Beispiele für einen unilateralen Transport zunächst auf der linken Seite an einer Tibia, bei dem wir einen antegraden Transport durchgeführt haben. Das war relativ unkompliziert. Wir haben allerdings die Weichsalzsituation durch verschiedene Lappenplastiken managen müssen. Hier das Ausheilungsergebnis nach etwa 3 Jahren. Der rechte Teil des Bildes beschreibt einen Segmenttransport des Femurs bei einem Patienten mit einer Fistel, mit einer chronischen Fistel, die wir hier herausgesägt haben und das gesamte Bein verkürzen mussten aufgrund der prekären Weichteilsituation. Wir haben dann zunächst den Transport retrograd angesetzt und bei dem Docking, bei dem wir oben die Frakturenden nicht genau getroffen haben, gestoppt und haben anschließend den Transport antegrad fortgesetzt, um die Beinlängendifferenz wieder auszugleichen. Dieser Patient befindet sich derzeit in der Narea, er kann Treppen steigen mit dem Fixateur und geplant ist, dass wir den Fixateur entfernen und anschließend durch einen additiven, soliden Nagel komplementieren. Hier Transporte, die wir über Nägel primär gemacht haben. Dort ein abgeschlossener Transport nach einer Schussverletzung, bei dem sich ebenfalls eine Kallusinsuffizienz gebildet hatte aufgrund exzessiven Rauchens. Wir haben dann auch hier den Transportnagel entfernt, weil dieser ja gerne bricht in den Transportsegmenten und haben diesen durch einen soliden Nagel ersetzt. Das Bild hier zeigt den Situs 5 Jahre später. Der Patient läuft ohne weitere Probleme. Die rechte Seite des Bildes zeigt dann einen komplizierten Verlauf bei einem Nageltransport, den wir über einen retrograd eingebrachten Nagel vorgenommen haben. Hier haben wir den Transport in 2 Etappen vorgenommen. Man sieht das an den unterschiedlichen Kallusausbildungen und hatten zusätzlich das Problem, dass sich die Schrauben hier unten gelockert hatten, sodass wir diese mit einer Platte fixiert hatten, sodass diese nicht mehr ausgewandert sind. Auch diese Patientin läuft. Sie hat uns ein Video geschickt, wie sie problemfrei Fahrrad fährt. Hier ein Transportnagel für eine Tibia, bei der wir einen retrograden Transport zunächst vorgenommen haben und ebenfalls Schraubenauslockerung mit einer zusätzlichen Plattenosteosynthese vermieden haben. Auch hier haben wir, weil das Docking hier oben sehr zögerlich war, einen additiven Nagel eingeführt. Dieses hier zeigt das Bild jetzt nach etwa 8 Jahren. Man sieht hier zwar noch eine Lücke, aber der Patient läuft völlig störungsfrei und hat keinen Infekt mehr gebildet. Hier haben wir ein Monorail-Verfahren anwenden müssen, weil der Defekt im proximalen Femur sehr hoch war, nämlich in Höhe des Trochanter minors, und wir für den Transportnagel keine vernünftige Verankerung mehr gefunden haben, sodass wir über einen Gamma-Nagel und einer additiven Verwendung des LRS-Systems von Orthofix einen antegraden Transport vorgenommen haben. Hier hatten wir die Komplikation von Ausriss von Pins, die wir anschließend neu gesetzt haben. Die Patientin wünschte dann im weiteren Verlauf die Entfernung ausschließlich der Schenkelhalsschraube, weil diese Probleme bereitet hat. Die Patientin läuft heute und ist ebenfalls frei von Rezidiv. Besondere Probleme bereiten diese Patienten mit Schussverletzungen. Da ist ein ukrainischer Soldat, bei dem etwa 12 cm des Femorschaftes noch mitgefehlt haben, sodass wir hier nach Sanierung des Infektes, hier oben sieht man noch den dislozierten Spacer, dass wir nach Sanierung des Infektes eine Prothese eingebaut haben. Dieser Patient befindet sich ebenfalls derzeit in der Narea, und zwar in der Ukraine. Hier ein anderer Patient, bei dem wir eine Schussverletzung des Oberarmes zu versorgen hatten. Dieser Patient hatte von vornherein eine Radialisparese, man hat das gerade an den Bildern gesehen. Wir haben hier vom vom Verlauf her ein freies Fibula-Transplantat implantiert mit dieser Plattenosteosynthese, die zugegebenermaßen etwas kurz geraten ist, aber trotzdem gehalten hat. Und haben anschließend noch eine motorische Ersatzplastik gemacht, bei der Sie gerade auf dem Bild gesehen haben, dass der Patient jetzt etwa 8 Wochen nach diesem Eingriff die Finger bewegen kann. Auch die Extension im Handgelenk gelingt zunehmend besser. Die Versorgung von derartigen knöchernen, aber auch so sehr ausgedehnten Weiterdefekten erfordert eine sehr individuelle Planung durch ein kleines, spezialisiertes Team. Und es muss als erstes die Infektion kontrolliert werden, ansonsten verbieten sich alle weiteren Maßnahmen. Wir haben ein sehr spezialisiertes Team aus Traumatologen und auch aus plastischen Chirurgen. Und es erfordert im Weiteren eine sehr enge Anbindung an eine Spezialambulanz, denn diese Patienten haben ja Behandlungsdauern von 1,5 bis 2 Jahren. Damit bedanke ich mich bei Ihnen allen. Ja. Bitte schön.
So, Schuster, thank you very much for the nice presentation. Yes, we can discuss the points. If you have any question, please now, and after the discussion, we have the possibility to make a break, okay, for coffee and some tea. First, yes, Professor Lorenzo Drago has a question.
I have a question for Dr. Enkel. I didn't understand which the acronym DACC is in your wound repair and how it works.
Thank you. And that is a Solbach technology. It works on hydrophobicity, so it binds bacteria based on hydrophobicity, and we know that is the most important factor there, and it takes it out of the wound so that it can't damage. They don't kill, it doesn't kill wounds, therefore there's no endotoxin in, or which just comes out of the bacteria.
So it interferes with the adhesion of bacteria?
Yes.
Okay,
There
thank
are
you.
some anchor proteins on binds to these.
That's good, thank you.
I have a question to Osman. The reconstruction, Shokat, excuse me, Osman Shokat, Shokat Gaza, excuse me, to Shokat, the reconstruction of the arc of the food in charcoal food.
Yeah.
Do you have any tips and tricks for us?
Okay.
Yes. You know what I mean?
I know. First of all, in most of cases of mid-foot charcot, in healed stage with ulcer or deformity or rocker bottom deformity, I used to do osteotomy like a deformity of the tibia or femur, varus valgus. There is rocker deformity. Is it planus or varus? So I do biplanar osteotomy by the saw, pre-operative planning by CT. Then I do the wedge osteotomy, plantar, medial or lateral according to the varus valgus. Then close and preliminary fixation by wire, thick wires. Then I use a guide wire for screw, for beaming, for intramedullary screw. Nowadays we use double compression screws, very, very good option for these cases. Then the first step and the important step in mid-foot charcot is tendo Achilles. Most of surgeons miss the primary pathology of the deformity. Tendo Achilles is the primary cause of mid-foot dislocation and the cuboid dislocation. When the cuboid dislocated, there's rocker bottom or exostosis or pressure sores on the foot. Yes. So we do exostectomy first and closed wedge osteotomy, then preliminary fixation or screw fixation, then late the last step is Elizarov application.
Thank you very much.
Thank
you very much. Yes. Any question? Uli?
Thank you for the good talk to Dr. Schöttes. You mentioned that after the clinical things are performed, that means the outdoor patient takes a long time, 2 years, you said 2 years. How are you managing these, let's say, ortho and plastic combined surgery outdoor patients? Do you have any rules how you do this in your clinic?
Also wie Sie die beiden managen. Ja.
In der Klinik haben wir plastische Chirurgen in unserer Abteilung und später werden diese Patienten über die spezielle Ambulanz für Rekonstruktionen weitergeführt. Und falls es erforderlich ist, werden die Patienten wieder stationär aufgenommen und können dann von plastischen und von traumatologischen Chirurgen versorgt werden.
Good morning, everybody. Thank you for the nice talk. I'm Lucien G., a plastic reconstructive surgeon coming from Oldenburg, Evangelisches Krankenhaus. I would have a question in regard of how do you decide, especially for long bone defects, whether you do a transport or you do a free fibula? Because I saw that you do free vascularized. So because we have a very nice cooperation between traumatology and plastic surgery in our hospital, and we are just beginning with setting out criteria when to do transport or when to do directly vascularized bone, like a fibula or a double barrel fibula, like you saw the nice case with the humerus, where we do like a double barrel, like to bridge the gap of the diameter, you know. So, but we are in the beginning, like to set out rules, and this would interest me, like how do you pursue like the analysis each case to say, okay, I do fibula or here I do a transport. Ich kann das auf, haben Sie verstanden? Okay.
Also am Humerus sind Transporte außerordentlich schwierig wegen des Radialisnerven. Wir hatten hier auch erhebliche Weichteilprobleme und da verbietet sich ein Transport. Und wenn man in der Literatur guckt, sieht man auch Transporte, zwar am Humerus, aber nur sehr kleine Transporte. Und das würde ich auf keinen Fall machen, dass ich dort oben einen Transport machen würde in einem Gebiet, in dem wir Probleme kriegen. Wir haben ja verschiedene Transporte gehabt, wo sich die Weichteile anschließend vor den Knochen gezogen haben. Und das würde man da oben sofort kriegen, das müsste man dann abbrechen. Und deshalb haben wir uns hier direkt für eine Fibula entschieden. Und der Knochen war relativ klein, deshalb haben wir auch nur eine Fibula und keine zwei genommen.
Meistens der Meinung, also Tibia zum Beispiel oder Finger?
Am liebsten.
Besser Transport? Also
ja.
Transport, weil Sie mehr Erfahrung oder?
Nee.
Also in unserer Welt?
Ich mache einen Originalknochen.
Okay.
Ich habe ja das eine Bild gezeigt von dem Jungen mit dem Docking. Die Transportstrecke sieht man nicht mehr. Weg, Originalknochen. Und wenn man da ein CT durchlegt, Originalknochen. Das ist fantastisch.
The next question, please.
Very interesting and nice presentation. Thank you very much. When you talk about these cancellous bone insufficiency and when you have cases where the final fusion after transport is not going further and is delayed, do you know the work from Werner Hetmer from Stuttgart? I saw him, or I met him on a European Society Biomaterials Congress last year in Turin, and he presented his cases. He has a lot of non-union and delayed union cases, and he applies locally zoledronic acid to reduce the activity of osteoclasts and to also reduce the osteoclastogenesis, to bring the balance more onto the side of mineralization. And he has very good results. Could this be an opportunity for your clinic and your cases as well?
René. Möglich, aber die Erfahrung habe ich nicht. Würde ich mir aber gerne angucken.
Also ich kann den Kontakt herstellen.
Lieben gerne. Lieben gerne. Also häufig reicht es, wenn man lange genug wartet Und wir haben einen Fall von einem Patienten, da haben wir über 2 Jahre gewartet. Der hat nicht überbaut, aber die Weichteile waren so schrecklich, dass wir gedacht haben, dann lieber eine stabile Pseudoarthrose. Und wir haben aus einem anderen Grund ein halbes Jahr später ein Bild gemacht, der war da überbaut. Damit haben wir überhaupt nicht mehr gerechnet. Das war der mit den 21 Zentimetern an der Tibia. Der ist plötzlich überbaut. Ich weiß nicht warum. Der ist einfach draufgelaufen. Dann ging es nach über 2 Jahren.
Okay, vielen Dank. Thank you very much.
Das ist auch die Definition der Pseudarthrose ist auch natürlich immer wieder werden wir überrascht, was der Knochen schafft. Was wir zum Beispiel bei nicht vaskularisierten Fibula-Transplantaten am Oberarm haben. Nicht vaskularisiert, lange Strecke funktionieren am Oberarm relativ gut. Also da kommt Elisa auch sowieso fast nie in Frage, das ist richtig. Any question, please? My last question, dear Carlo, 1 stage against 2 stage. Do you know, can we say in the future, is 1 stage is the standard, gold standard in periprosthetic infection or no?
I think this depends very much on the patient that you have, on your experience, and on the technologies that you have available. But I think that in the future, the number of 1-stage revision will grow substantially.
I think so too. Thank you very much. Any questions? Thank you very much for the speakers for the first session. I think we have to make a break, and the next session will begin in 15 minutes approximately. Thank you.
Thank you. Good.
So, ladies and gentlemen, I have changed just a little the flow of the program as we have a very important organization in our state, in Germany. And this organization has the name Friedensdorf International. This organization has the responsibility and with much engagement bring from the war regions children with accidents and with trauma and with mainly osteomyelitis, is the theme of the Congress, to Germany, or many hospitals enable, and we hope it, to treat this patient, and from these children don't need to pay. Yeah. And this organization, we are very happy to have this organization, and we want to give this organization, Friedensdorf International, the chance to present this organization. And the main local area is in the near of Recklinghausen in Oberhausen. Yes. In Oberhausen in the near. Thank you very much for your coming. The stage is yours.
Yeah, thank you very much for inviting us, and I want to present to you the work we do, our organization. It's called Friedensdorf International, which you can translate as Peace Village International. And like said before, we are located in Oberhausen, which is about half an hour, depending on the traffic, away from here. And I will show you a bit of what we are doing. Like said before, we are taking children from war and crisis zones all over the world to Oberhausen to give them the chance for medical treatment here in Germany and in Austria as well. But most of the hospitals are located here in Germany, but all over Germany, not only in North Rhine-Westphalia, but all over Germany. So what are we doing? We are doing our work since 1967, so we are getting 60 by next year. Like I said before, we are providing treatment for injured and sick children from war and crisis zones. But we also do sustainable projects in our countries of operation to improve the medical situation in the countries. And we also do educational work based on peace education here in Germany. We are active in 10 different countries. You can see we are basically working in countries of Africa, also Central Asia, and our headquarter and home is Oberhausen in Germany. Most of our children, the biggest amount, come from Afghanistan and Angola, and a lot of these children are facing problems with osteomyelitis, which is the biggest number of injuries that we have in Peace Village. So this is our facility. This is the view from above. I will go into detail now and show you what we are doing there. So we have the housing. We have about a constant number of 200 children at our facility permanently. We are offering the houses with 24-hour of supervision. We are offering dining, so we have fresh cooking every day for the children, 3 meals a day. And of course, besides the medical treatment, we give them time to play and to be kids. We have playgrounds all over the place. And we also have a sports field and an indoor field for sports, especially for the children that love the sports. Football is always the number one, and they really enjoy their time with us. We also have a medical center directly at our place. It's run by doctors and by nurses. We can do some treatments already in the medical center, so we don't need to bring the children to hospitals. Most of the doctors doing surgery in the medical center are doing it as volunteers. The medical care is minor outpatient procedures, and the surgeons, like I said before, are coming and working on a volunteer base in our theater. And we also have permanent rehabilitation for physiotherapy, in our location, and we are giving the medication and the after-post care, which we also do. We also have a learning center, so the children can learn permanently. We have a lot of volunteers that are offering the typical subjects like primary level of math or teaching the language, the home language of the children, but we also have volunteers that are offering music courses or playing groups. So we try to give the children as much of education as possible, because obviously when they are with us, they cannot go to their schools in their home country, and they're also not going to the schools here in Germany. Maybe it's also interesting for you to know that the children stay at an average of 6 months to 1.5 years with us. We also have an education center, which is education for people that come from outside. We have a meeting place where we offer extracurricular learning. We also give the opportunity to get in touch with our work. So we have a lot of schools that come to us. We have a lot of groups that come to us from different organizations that do social days with us. We also have, like shown before, football clubs that come to us with their younger teams like Borussia Dortmund or Schalke, which come to us, and they love to spend time with the children. And it's also for us really nice to see that a lot of companies, a lot of clubs from around the area are connecting with us. And which is one of our basic works, is we offer individual case assistance in the country, and this is how it looks. We give parents the opportunity to present their child when we are in the country. We try to be in every country at least one time a year. Sometimes we have the chance to go down there more. We have doctors with us that look at the cases of the children, and if we can confirm the treatment of the children, we start the preparation process. So the children get passports, get visas, which is also difficult for us, but we can still manage it. And then we have a charter flight for the bigger countries of operation, like Afghanistan, for example. Then we have a charter flight once a year that is flying from Düsseldorf to Kabul, or from Düsseldorf to Angola, to Luanda, to get the children to Germany. And directly after landing, the treatment of the children starts, either in Peace Village, in the medical center, or in the hospitals. And after they are completely recovered, they fly back home to their families, so the children are not staying permanently in Germany. After treatment is finished, they fly home to their parents as soon as possible. We always try to build like small groups that can fly home, or we also use the charter flights to fly them back home. And we offer lifelong medical care if needed. So if the children need medication in their home countries, we bring the medication with us to the home countries, or try to order the medication in their home countries if the medication is available there, which is kind of a problem sometimes. We also do the project work. This is an example of Afghanistan, but we also do project work in Uzbekistan. We also do it in Angola. So we have cooperations with several hospitals that are named here, and they are doing a lot of work for us. To get a number, we have about 170 patients in the country of Afghanistan that are done by the hospitals there. So we have a lot of osteomyelitis cases that are done by the Cure Hospital. We have a lot of urological surgeries that are done by the Star Medical Hospital. So we try to also give the children the opportunity to heal in their home countries, because we made the experience that it's way better if the children can stay with their families, of course, but the more difficult cases need to be treated still in Germany. We also offer immediate assistance in the countries, like we offer food packages, health kits, especially after natural disasters like flooding or problems with dry seasons, and we also offer this. And we offer like basic medical equipment, wheelchairs, walking aids, bandages in the countries, because the biggest problem in most of the countries is that they have the knowledge, but they do not have the material, and they do not have the supplies to work like they wish to work. We also offer social projects. here's a case from Afghanistan again, which we are financing, and we build playgrounds. On the other side, you can see we offer a place for physiotherapy. This is a case from Tajikistan, so we also try to work on the social base. And if you're interested in what we do, you can get involved. You can volunteer in wide areas in our organization. You can volunteer as a doctor. This is what was mentioned before. So none of the kids have to pay for their treatment. So we are really rely on volunteer work, either from the doctors or from the nurses or from people that want to get involved. We are always offering the free treatment. So we are looking for sponsors. We are looking for volunteers here in Germany. What also helps a lot is just sharing your expertise. Like if we have cases that we are not sure if we can take them, or if we are not sure what the child is suffering from, we can send emails to you, and you can help with your expertise to just evaluate the case. That helps a lot. And obviously you can always make donations or just share the words. Like if you like what we are doing, just share our idea, tell it, so that most of people know from the work of Peace Village. Yeah, thank you very much. And if you have any questions, feel free to ask.
Thank you very much for a nice presentation. We can discuss at the end of the session. Thank you very much. Unfortunately, we come from war to the next war. And this is my friend Bernd Franke, one of the most engaged people that I know, and his activities are in the area Ukraine. Please.
Also, thank you very much. Oh, we can open this one. Oh no.
Du wisst aber, 11 Uhr ist, Bernd. Ja. Ist das richtig?
Ja.
Nee. Okay, da hast du das.
Thank you very much for your interest, ladies and gentlemen. Thank you very much for the invitation to speak here to you. I will invite you to open your smartphones. Why? I will speak next time in German language. So why? It's much more easier for me to give you all information about what I'm doing. And also the video is online, and I'm not sure if we can spend the video from YouTube later by KI, the option to switch the language to French or English or whatever else. For myself, okay, I like to begin in English. My name is Bernd Franke. I'm not a doctor. There's a mistake in the short mistake. I'm not a doctor. I'm an orthopedic shoemaker master, craftsman master, and international master science at 2080. And I travel as a craftsman around the world to give all information about my doing or my experience to people who need it. And some of them was in Ukraine. So the question for this moment was, how is the structure of Germany to create or prepared for a scenario? Wir sind ja dabei, uns Gedanken zu machen, wie gehen wir um mit den künftigen Möglichkeiten, die uns erwarten könnten in Deutschland oder in Europa. Und solange wir auf einem Dampfer sitzen, der in voller Fahrt in eine Richtung fährt, sind wir uns alle sicher, weil der Raum ist begrenzt, in dem wir uns bewegen. Wir brauchen uns keine Sorgen zu machen, aber es sei denn, es kommt von irgendwo außen etwas, dann ist es ganz schwerfällig, so einen großen Tanker in voller Fahrt in eine andere Richtung zu lenken. Deswegen haben wir dieses Sinnbild hier vorne mit drauf. 2023 war ich erstmal in der Ukraine und sah dieses große Bild an einer Hauswand kleben, wo ich mich gefragt habe, ist das wirklich so, dass es mal in Frage kommt? Kann sowas passieren? Mittlerweile darf ich allen sagen, und die da hinten, die es natürlich besser kennen, genauso gut kennen wie ich, hat sich die Form eines Krieges so gewandelt, wie sie noch nie zuvor da gewesen ist. Wir haben es mit Technologien zu tun, an die hat man vorher nicht gedacht vor diesem Krieg. Und wir sind plötzlich überwacht von allen Ecken und allen Kanten, dass wir das Problem aktuell haben, auch gerade in der Ukraine, dass Soldaten, die eine Verletzung erlitten haben, in ihrem Schützengraben eigentlich sterben werden, weil sie keine Chance haben, aus dem Graben herauskommen zu können. Es gibt keine Versorgung. Es kann niemand in diesen Graben fahren, um sie rauszuholen. Das ist eine Kriegsführung, die mittlerweile stattgefunden hat, mit der wir uns beschäftigen müssen, auch in diesem Land, auch in den NATO-Ländern, wie wir damit künftig umgehen werden. Ganz kurz, Background-Historie. Die Orthopädie-Technik, die ja in der Ukraine ganz groß geschrieben ist, weil sie auch gebraucht wird, wie auch in vielen anderen Krisengebieten, ist mittlerweile ja über 3000 Jahre alt. Die Ägypter haben ja nun ihre ersten Produkte hier mal bei den Mumien gezeigt, die wir gefunden haben. Im Gegensatz dazu ist der Beruf, den ich ausübe, als Orthopädie-Schuhtechnik, erst aus dem Zweiten Weltkrieg unseres Daseins entstanden, aus der Schuhmacherei, also verhältnismäßig jung. So, wir sind erst im Jahre 1958 in eine Handwerksrolle eingetragen worden und man hat sich da erst Gedanken über Füße und wie versorge ich Füße gemacht, was vorher nie der Fall war. Vorher hat man einfach eine Hülle gebaut um etwas und jetzt haben wir es damit zu tun, Versorgung mit anderen Strukturen in Gelenkflächen zu versorgen, mit Verbrennungen, mit eingeschränkten Gelenkflächen, mit dem diabetischen Fuß, der in unseren Regionen ganz groß ist, aber auch weltweit groß gefragt wird. Bevor der Ukraine-Krieg begonnen hatte, hatten wir 11 Orthopädie-Techniker Meisterkategorie 1 nach ISPO, International Society for Prosthetics and Orthotics, die weltweit eine Ausbildungsstrategie haben, die anerkannt ist und überall gleich ist. Diese sogenannten Meister ihres Faches, 11 Stück, es wurden nicht mehr gebraucht, weil das Land damals auch keine Versorgung hatte in dem Sinne. Und wenn ich jetzt sehe, dass 2025 erst 36 dieser Meister geschaffen wurden in den letzten 3 Jahren, dann hat das eine Historie, weil ich brauche, um diesen Meistergrad zu erreichen, unterschiedliche Stadien der Ausbildung. Das heißt, nach diesem 3-3-3-System ich insgesamt 9 Jahre brauche, um als Meister akkreditiert werden zu können, habe ich bis dahin einen wahnsinnig großen Verlauf an Versorgungen, die mitunter nicht richtig funktionieren, zum Leidwesen. Ich projiziere das als Frage auch auf unser eigenes Land, weil wir haben, alle Handwerksbetriebe sind ja ausgelastet. Ich habe ja keine Reserven, die ich irgendwo herholen kann und so fangen die jetzt auch an und nehmen Menschen von der Straße weg, als Maurer, als Dachdecker, als Zimmerleute, als Stuckateure, als Studenten und versuchen sie auszubilden mit aller Gewalt in diesem Handwerk, weil es gerade gefragt wird. Es braucht also eine lange Zeit, bis sie so weit sind, dass sie was können. Und das heißt aber auch im Umkehrschluss, dass es 7 bis 10 Jahre brauchen wird, bis der letzte Veteran überhaupt seine Erstversorgung bekommen hat. Das muss man sich mal auf der Zunge zergehen lassen, weil einfach niemand da ist, der es machen kann. So, Ausbildung in der Orthopädie-Schuhtechnik ist von russischer Seite vor schon 20 Jahren finanziell so weit runtergeschraubt worden, dass es gar nicht interessant ist, darin auszubilden. Das heißt, man hat dieses Berufsbild, soweit es das mal gab, völlig auf Null gebracht und fängt jetzt erst an, darüber nachzudenken, auch da wieder einen gewissen Aufbau stattfinden zu lassen, der aber politisch gesehen erstmal langsam wachsen muss. Dabei ist aber die Rate der Versorgungsnotwendigkeit bei diesen 4 bis 6% der Bevölkerung notwendig. Wir sprechen nicht von einer Diabetesrate, die schon fast so hoch war wie in Deutschland vor dem Krieg. Und jetzt haben wir eben die großen Versorgungen der Veteranen mit dabei. Wie viele Center haben wir in Deutschland, die irgendwas in der Richtung bewegen könnten? An Menge? Gar keins. Wo haben wir Center, wo wir die einrichten könnten? In Westerstede war nochmal die Frage, wir machen 3 im Norden, Süden und in der Mitte Deutschlands. In der Mitte Deutschlands sage ich jetzt hier einfach mal, wir haben ganz viel Untergrund, der leer ist, wo man was drin schaffen könnte, ohne dass man mit Drohnen reinfahren kann. Aber wir haben nach wie vor dasselbe Problem, wir haben keine Fachkräfte zur Hand. Das heißt, wir müssen ja auch in eine gewisse Resilienz gehen, um Menschen auch politisch im schulischen Bereich in eine Richtung zu bringen, die sich wieder mehr mit Handwerk und diesen Thematiken beschäftigen, mehr als zuvor. Wir werden das nicht alles über europäische Vereinigungen schaffen können, zu kompensieren, wenn es mal dazu kommen sollte. Wenn wir also jetzt gerade mehr als 100.000 Veteranen haben, die in der Ukraine versorgt werden sollen, dann gab es die Idee, damals noch unter Karl Lauterbach, eine Versorgung stattfinden zu lassen, möglichst nahe der polnischen Grenze. Das Ganze fand in Lviv statt und dort hat der deutsche Staat sehr viel Geld investiert über Steuergelder und hat es geschaffen, erstmal eine Werkstatt aufzubauen in einer Größe von 1000 Quadratmetern für die Orthopädie-Technik. Und man hat es genauso geschaffen, ein riesengroßes Reha-Center zu erweitern, auf das ich ganz zum Schluss noch kurz eingehen werde. Bau einer solchen Werkstatt zu 100% aus der Ukraine, in der Ukraine produziert. Baubeginn Oktober 23. Im April 24 war ich dort und habe die ersten Ausbildungen innen drinnen schon betrieben und die Einrichtungen dort reingebracht. Da war außen noch Baustelle gewesen. Und im Mai hat unsere damalige Ministerin Svenja Schulze das Ganze mit eröffnet, mit dem Bürgermeister der Stadt Lviv, mit dem dortigen Chef der Gesellschaft für internationale Zusammenarbeit und Versorgung, die wir dann eben dort erstmals gesehen haben und uns Gedanken gemacht haben, der Orthopädie-Technik. Wie können wir sie versorgen? Mit welcher Art und Weise sind wir mit den Technikern, die wir hatten, 2 Kategorie 1 Meister sind dort vor Ort gewesen, haben wir sie besprochen. Das sind Bilder, die gehen heute gang und gäbe überall rum. Menschen, die eben in der ersten Linie vorversorgt wurden und hier in der Reha-Abteilung eben nachversorgt werden. Für manch einen hier im Haus nichts Neues, nichts Besonderes. Viele werden amputiert. Nicht alle, so wie hier auch zu sehen, werden mit Prothesen versorgt werden können, sondern der junge Mann auf der rechten Seite, der kann vielleicht links eine Prothese tragen, aber rechts hat den Stumpf und da ist noch ein Schuh dran zu tragen. Oder da kommt keine Prothese dran, beispielsweise. Und da ist dann Handwerk, wie meines in der Orthopädie-Schuhtechnik, eben sehr gefragt. Wie geht man um mit solchen Verletzungen, wo einfach Dinge fehlen? In Kriegszeiten ist das noch nicht so relevant, aber später, wenn die Menschen wieder zurück in das soziale Leben sollen, wird es relevant sein, wenn eben Gliedmaßen fehlen, die sonst in der Dynamik sehr viel Kraft abnehmen und ihm das Leben erleichtern. Unterschiedliche Stumpfversorgungen, wie wir sie eigentlich nur, wie rechts im Bild, Bücher direkt nach dem Krieg noch sehen, weil aktuell gibt es keine neuen Fachbücher in meinem Berufszweig, der über Versorgungsmuster beschreibt, wie man sowas angehen könnte, mit welchen neuen Technologien man sowas angehen kann. Da wird ja auch viel in der Ausbildung jetzt gemacht mit KI, 3D, aber da kommen wir gleich noch drauf. Auch hier, wir haben Ausbildung betrieben vor Ort, noch in der alten Werkstatt. Eine Kollegin von mir, die war mit. Stumpf vermessen, gegipst, unterschiedliche Varianten der Anproben gemacht. Das sind Menschen, die ja nicht nur einen Stumpf haben, die kommen von der Front, die sind mehrfach verletzt durch Minen, die haben Brandwunden, die haben noch Splitter im Körper drin, die fangen wieder an zu eitern, die Wunden gehen auf, die müssen nachversorgt werden. Also eigentlich ein Dauerbrenner, wie wir sie hier in Europa westlich gesehen gar nicht kennen. Wir haben einen Unfall, Trauma, wird operiert, versorgt, fertig, nächste. Das haben wir ja hier nicht. So, dieses Center, was mache ich als Handwerker? Ich nehme einen Rucksack, Backpacker, fahre dahin und gucke, was habt ihr denn vor Ort? Ich bringe nichts mit an Maschinen, ich bringe nichts mit an Material, sondern es geht darum, Menschen mit dem zu helfen, was man vor Ort hat. Und mehr als das, was ich hier zeige, brauche ich in der Regel nicht. Also geht es da rein. Wir sehen, wie die ehemalige von mir eingerichtete Werkstatt jetzt praktisch gebraucht wird. 3D-Technologien haben wir da, alles vom Neuesten. Nichts ist gebraucht, alles vom deutschen Staat, von unseren Steuergeldern gut finanziert worden und es wird benötigt. Definitiv. Interessant, da hinten der alte Laster, der noch fährt, aber vorne eine High-End-Prothese, die der Patient am Fuß trägt. Muss es immer High-End sein oder wie viel High-End ist PR, um damit andere Gelder zu generieren? Die Facharbeiter, die hier dort ausgebildet werden, werden aktuell mit Technologien zugeschüttet, die sie gar nicht beherrschen. Es gibt große Firmen auf dem Markt, die sich dort die Ölkännchen verteilen, aber das Öl nachher noch bezahlt haben möchten. Und so liegen ganz viele gute, sehr gute Systeme, die auch funktionieren, einfach brach in der Ecke und werden nicht benutzt, weil es der Fachmann nicht anwenden kann, zum Leidwesen. Spätestens hier war mir klar gewesen, dass mein Berufsbild dort sehr gut gebraucht wird. Die Prothese auf der linken Seite passt wunderbar, aber er kam wegen seinem rechten Fuß und da hat der Orthopädie-Techniker nicht mehr gewusst, was er machen sollte. Warum ist das Gelenk eingeschränkt? Wie funktioniert ein Fuß? Das hat ein Techniker in der Form nicht gelernt wie ein Orthopädie-Schuhmacher, weil für den Techniker gibt es ein Sprunggelenk, ein Knie und eine Hüfte. Aber für uns gibt es 26 Knochen am Fuß und das ist was anderes. Und da haben wir mehr Dynamik und Flexibilität drin. Und deswegen ist es wichtig, solche Botschaften auch mal nach außen zu tragen, was man alles machen kann. Also Füße in die Hand nehmen, palpieren, tasten, Digitalisierung mit einpflegen in die aktuellen Versorgungsstrukturen und nicht nur altes klassisches Handwerk wie hier im Gipsen. Modellieren nach Modellen, die sich Menschen einfallen lassen, als Idee aus dem Internet geklaut und gleich umgesetzt, orthopädische Schuhe gemacht, damit so ein Schuh nicht mehr aussieht wie schlicht, schwarz, einfach, sondern wunschgemäß, wie es der Patient gerne haben möchte. So operieren Sie alle, das weiß ich, und so wollen wir auch genauso im Handwerk weiterarbeiten. Versorgung für Stümpfe in einer Variation, wie ich sie aus Deutschland kenne. Wir haben ganz unterschiedliche Varianten dieser Stumpfversorgung gemacht, weil ganz viele Patienten ja wieder zurück an die Front gehen und die Dynamik eines Stumpfes anders sein muss, als wir es bei uns im Handwerk hier gerade praktizieren. Wenn ich also wieder in Vorlage gehe, um das Gewehr nach vorn zu halten, habe ich eine andere Fußstellung in der Extension, als wenn ich ganz normal spazieren gehe. All die Dinge haben wir durchexerziert in einem Prozess von 8 Wochen, um sowas zu realisieren. Und wir stellen fest, dass die Nachfrage nach wie vor hoch ist. Nur die Politik ist noch nicht dabei angekommen, dieses Thema genauso mit aufzunehmen. Eine Prothese wird immer noch High-End bezahlt, da gibt es überhaupt keine Grenze. Aber ansonsten, was im Low-Level-Bereich unten versorgt werden kann, da ist einfach noch ganz viel under low. Ganz kurz, wo ich da bin, Unbroken ist ein Rehabilitationszentrum in Lviv. Lviv selber liegt 70 Kilometer von der Grenze Polens entfernt. Und dieses Gebäude, was so aussieht, ähnlich wie ein Eder unten, da fallen gleich 800 Betten rein. Das war das Grundgebäude, was es mal gab. Und das wurde erweitert durch eine Rehabilitationsanbau mit 10.000 Quadratmeter. Man ist gerade dabei, einen Operationssaal zu planen, 25.000 Quadratmeter Fläche. Man hat Unterkünfte für Angehörige geschaffen, die mietfrei dort wohnen können, solange die Patienten, die Veteranen, versorgt werden. Man hat eine Schule dort für 1.500 Schüler, damit die zeitgleich weiterleben können. Man hat ein Kinderhospital. Man hat ein Zentrum für die Soldaten, die im Trauma noch versorgt werden müssen, ebenfalls wie das psychologische Zentrum und das Forschungszentrum für diesen Bereich der Kriegsführung. Das Ganze, meine Damen und meine Herren, befindet sich auf einer Fläche von Entfernung 1,5 Kilometer. So zentral, wo alle Notwendigkeiten an Versorgungen in Struktur über ein Haus, über einen Server, über eine Informationsstelle und Schnittstelle läuft. Da müssen wir mal hinkommen. Und der kleine Workshop da unten, in dem ich tätig war, der fällt ja einfach nur ab als Garage. So weit, so gut. Die Soldaten, Sie sehen es auf dem linken Bild, die sehen es teilweise mit Humor, dass sie jetzt so aktiv unterwegs sind. Übrigens wird in der Ukraine eigentlich keine Prothese mit irgendeinem Wadenschaft versehen, sondern man feiert diese Menschen als Helden im Land. Man geht ganz anders um dort mit, als es bei uns überhaupt bekannt ist. Und wenn Sie noch Fragen haben, würde ich mich freuen, gerne auch über E-Mail, über die Website. Herzlichen Dank.
Dear Brent, thank you very much. The technical orthopedic is a very important thing, and it's interesting to know that in Germany we had only zero center, and we had to decide to have more center and teaching centers. It's a surprise for me, the information. Thank you. We can continue with Dr. Moisa from Ukraine. septic arthritis of major joints after war injuries, etiological patterns, and clinical characteristics. Please. Yes.
Hello, everyone. Good afternoon, dear colleagues. Thank you, Frank, for your job. It's very great. It's very important for us. Thank you. Today, I will present our experiences managing septic arthritis of the major joints after combat injuries and discuss why this condition should be considered a distinct clinical entity. Since 2014 and 2022, Ukraine has faced an unprecedented number of severe combat injuries. Unlike civilian trauma, battlefield wounds are associated with massive contamination, extensive soft tissue damage, repeated surgical process, and prolonged evacuation. As a result, infections become more aggressive, more resistant, and much more difficult to eradicate. Aim of the study was analyzed clinical and microbiological characteristics of septic arthritis of the hip and knee joints after combat injuries and compare them with civilian cases. We retrospectively analyzed 37 patients after combat injuries and compared them with 106 civilian patients. We evaluated clinical presentation, laboratory findings, microbiological cultures, and treatment outcomes. This slide demonstrated the major difference between military and civilian infections. In civilian patients, Staphylococcus aureus remained the dominant pathogen. In contrast, combat-related infection demonstrated a much higher prevalence of gram-negative microorganisms, particularly Klebsiella pneumonia and Pseudomonas aeruginosa. This finding has important implications for empirical antibiotic therapy. Polyinfection was identified in 25.6% of military patients, compared with only 7.3% in civilian patients. Is different was statistically significant. This finds confirms that combat injuries are associated with a substantially more complex microbiological environment. Another important observation was the presence of resistant pathogens. We identified MRSA, Klebsiella pneumonia, and Pseudomonas aeruginosa among the clinically significant microorganisms. These pathogens often required target and prolonged antibiotic treatment. Timing was another critical factor. We observed a statistically significant difference in the interval between injury and surgical treatment. Delayed management was associated with chronic infection, extensive tissue destruction, and more complicated reconstruction. Severe failures contribute to the unique natures of combat-related infections. These include massive contaminations, resistant hospital flora, repeated surgical processes, biofilm formation, and delayed evacuation. Together, they create a highly challenging environment for infection control. It's a first clinical case. This patient's development post-traumatic septic arthritis after combat injury. Treatment included debridement, infection control, and staged reconstruction. After irradiation of infection, successful joint reconstruction was achieved. This case demonstrates severe joint destruction caused by delayed infections. This patient have very soft tissue defect, massive, required multiple surgical procedures before definite reconstruction could be performed. In this patient, infection control was achieved toward resistance arthroplasty followed by staged reconstruction. This illustrated the importance of stepwise treatment in complex combat-related infection. This case represents the most severe scenario. Extensive infection and osteomyelitis progressed despite multiple interventions, ultimately resulting in limb loss. It highlights the consensus of delayed treatment persistent infection. Based on our findings, combat-related septic arthritis requires an aggressive multidisciplinary approach. Successful treatment depends on radical debridement, staged surgery, early microbiological diagnosis, and target antibiotic therapy with appropriate gram-negative coverage. In conclusion, related septic arthritis differs substantially from civilian joint infection. It is characterized by resistance gram-negative pathogens, a higher prevalence of polymicrobial infection, and delayed clinical presentation. Recognition of this difference is essential for successful infection control and limb preservation. Thank you for attention. All colleagues. And finally, I would like to invite our colleagues to join the upcoming Ukrainian Bone and Joint Infection Forum from Kyiv. I think it's very interesting for you guys. Maybe do you have a presentation online, offline? We're very happy for this. Thank you.
Thank you.
Thank you.
Thank you. Thank you very much, Dr. Moisa. You need one of the most, the fact is one of the most important prevention aspect, prevention possibility to avoid infection is to avoid wars. Yes? That's correct. Yeah. There. Thank you. Dear friends, you can find on your desk an invitation. And on invitation, this invitation, you had the paper on your desk. This invitation is for you, 18 or 19, also 7 o'clock in the afternoon. 7 o'clock in the afternoon today. We have a get-together party, eat and drink. We invite you. That is in the center of Recklinghausen, in the just near of the Park Hotel or Engelsburg. And I would be very happy to see you today afternoon. Yes, okay. The next lecture belongs to Dr. Seyam. Dr. Seyam, René, you try, okay. Ich weiß, hast das Gefühl, die Präsentation von ihm, kann er mich hören? Ja, okay. Dr. Seyam?
Hello.
Dr. Seyam?
Yes.
Hello. Thank you for your coming in our online area.
Yeah, I'm coming. Do you hear me, please?
Yeah. Dr. Seyam,
you hear me?
Yes, thank you. Dr. Seyam, can you hear me well?
Yes.
Okay,
Yes,
we can hear you well too. Thank you for your lecture. You have the possibility to have the lectures, the number 1 and number 2. And thank you very much for your engagement. And you can begin with your lecture, your presentation now, please.
Okay. Okay, thank you very much for having me at this WAIOT conference. I was planning to be physically with you, but unfortunately, some things happened prevent me, so I'm sharing online. Okay, today our first presentation we will start about limb salvage in one ankle high velocity gunshot injury. After that, we will start with the algorithm, how we treat these cases in Gaza. As you know, in Gaza, in between 2018 to 2020, more than 15,000 gunshot injuries of Palestinians who were demonstrating in the borders has happened. In Gaza, we have a collaboration between Ministry of Health and Doctors Without Borders, MSF, to implement reconstruction of osteomyelitis unit, as we have thousands of cases with chronic osteomyelitis. Today, our case is a patient with devastating gunshot injury to his left ankle. He was 23 years old with high gunshot velocity to the left ankle. The lateral wound was small, as you see here, the medial exit of the bullet. The medial exit of the bullet shows you the wound. As you see, it's like not salvageable at all. When we first met with this case, we discussed with him, actually, to be honest, amputation. The patient refused and his family refused. He was claiming that he still have a sensation in his toe, maybe the sural nerve of the lateral side, but after more than 3 hours of discussion every day, he refused amputation. As you see here, no, with the present, okay. This is the exit of the wound, the talus is gone, the distal tibia is gone, only remaining of the hind foot is the calcaneus and the remainder of the foot. Fortunately, the dorsalis pedis pulse was there. As you see here, all the posterior tibial tunnel contents are gone. You see here will be the Achilles. Everything in the posterior tibial tunnel is gone. So the patient claimed that he has plantar sensation was just for psychological things because he refused amputation. Okay, how we treated this? After we discussed with the patients and the family, and they refused amputation at all, we discussed the plan comprehensively with them and tell them whatever the patient may suffer many operations, at the end, he might also end in amputation. They were consented for this. This case was done in 2020. Okay, we found the medial ankle wound is infected, the talus completely crushed, the structure of distal tibial articular surface, and post-traumatic osteomyelitis. The patient arrived us after 3 weeks. We set together physical therapy, orthopedics, and IV teams in plastic surgery. And we start to think we could reach a point that if we could shorten this limb through an arthrodesis between the calcaneus and tibia, we can manage this big and huge soft tissue defect. Okay, what the challenges in this case, there was a massive bone loss, a huge contaminated soft tissue defect, established acute contagious osteomyelitis, post-traumatic, and loss of plantar sensation, high risk of limb loss, and chronic infection. This is about discussion with the patient, I have already said. The multidisciplinary team approach the Doctors Without Borders with Ministry of Health collaboration. We did every day we do meetings, and every week we do meetings for the OT list. The case discussed with plastic surgery and infectious disease teams. Decision made to proceed with a staged limb salvage as the patient refused amputation at all. We decided our goal. What was our goal? To eradicate infection, achieve bone coverage, and solid fusion. We saved the patient limb. Our first surgical management we did for this patient, extensive radical debridement of bone and soft tissue. We took a 5D culture from the bone and soft tissue, and usually we do massive debridement and we apply our negative pressure wound therapy on a clean bed. Some concept somewhere in the hospital in Gaza about the concept of negative pressure wound therapy. According to Ministry of Health of Gaza and Doctors Without Borders, the negative pressure wound therapy is applied to decrease the void in the soft tissue. This is the main purpose, not to treat infection. So we did a very radical debridement of everything, any piece that looks infected or contaminated. We removed everything. We did acute shortening, and we applied the negative pressure wound therapy. I will tell you what was our aim. Before this operation and debridement, the targeted, we stopped antibiotics for 7 days, and we give targeted antibiotic therapy according to tissue culture and bone culture results after. And rifampicin, we usually include rifampicin in our antibiotic protocol after for the coating or the coat that bacteria develop around the hardware. Okay, this is the result after the first debridement and 4 days of negative pressure wound therapy. We wanted to make this soft tissue void as a coverable void, not keep it like this. We wanted to reach a result to finish from this void. It was a big challenge. Our thinking was if we did shortening arthrodesis, typical calcaneal arthrodesis, this void will decrease. Negative pressure wound therapy will help us more in decreasing it further, and so it can be graftable or with a flap we can treat. The talus is gone, completely debrided. Calcaneotibial arthrodesis is done, is the only viable reconstructive option we could have as the patient refused amputation. Intentional shortening performed to gain soft tissue coverage across ankle external fixation was used for strong immobilization, negative pressure wound therapy. Performed the CI, we did the first debridement and applied negative pressure wound therapy. After that, we opened after 10 days and applied another negative pressure wound therapy. The coverage of this one, this is the X-ray here on the left after calcaneotibial arthrodesis, the first X-ray. And here is a photo with the wound and the granulation tissue wall as graftable. We discussed with plastic surgery if the patient was need flap or graft, and they decided, two plastic surgeons actually decided it's to have a graft. This is the photo after split thickness skin graft here on the medial side. This is at the day of grafting. This photo at the day of grafting, this is on the right, 1 week after grafting, 3 weeks after grafting. The follow-up CT scan done at 3 months. It confirmed a solid arthrodesis union. We started a gradual weight bearing and initiated fixator dynamization by decreasing the tension of X6 so the bone can strengthen itself, the healing. External fixation removed at 4th month. The patient achieved full weight bearing by the 5th month. And residual limb shortening, there was the patient used the shoe lift and refused to do high tibial lengthening through distraction osteogenesis. This is the X-ray after 4 months. We have a solid union confirmed by CT scan. So the functional outcome was very good for this patient. This patient refused amputation. He got a solid union. The shortening, he said, I have to overcome it by shoe lift. I don't want to do more surgeries. He was very happy and satisfied. Thank you. I will show you the videos of this patient now. This is his first video. This is at the 2nd month after the operation. You see here the cross ankle X-fix, and we started supported weight bearing with elbow crutches. And here is the second video at 4 months, 7 days after removal of the X-fix and solid union of his arthrodesis. Thank you very much. We will proceed to the next lecture because Dr. Tisbali told me about shortage of time.
Dr. Sayab, you have the possibility to have the second, your second lecture.
Yeah.
You can continue, please.
Yes. Yeah, please, yeah. I will continue how we achieve union and treatment of these cases in Gaza. Now you see, I'm talking, now there are tens of thousands of injuries in Gaza. This about our experience in 2 years from 2018 to 2020. Okay, and this is my disclosures. In 2018, we talk about mass casualties, more than 4,000 gunshots. El Shifa Hospital in 14th of May 2018 received more than 670 gunshots within 10 hours. Those injuries ranged from superficial wounds to complex fractures with vascular injuries. More than 15 operation theaters worked continuously through the crisis. This is the photo. We have a big crisis that day, mass casualty, patients everywhere, no beds, all beds more than 300% of bed capacity. The injury sites of those 3,000 were in the leg tibia 67%, in the femur 20%, the humerus 4%, and as you see. We talked already about the MSF role in conflict-related osteomyelitis in the Middle East. MSF has implemented an osteomyelitis unit in Gaza and one in Iraq, in Mosul, and also in Amman for the severe complex cases. We were referring some patients to Amman Center. Part of osteomyelitis project in Gaza, it was there. We have 18 bed isolation and 2 operating theaters to support. We have 2 floors of private hospitals we rent to expand the capacity. This is a photo of the pre-operative area in Shifa Hospital, 14th of May 2018. As you notice, it's a big crisis, mass casualty, more than 670 patients in the hospital. No one could control. It was out of our hand. You see this man here on the left, he's the ID doctor, he's watching. He doesn't know what to do. We don't have any solution. Okay, the mass casualty, we had that more than 130 vascular injuries at that day. From 670 patients, we had 130 vascular injury. We have to prioritize them before anything else for limb saving. This is one case, gunshot in the forearm. We did only an X6, washing, debridement. Okay, the challenges encountered, why these thousands of osteomyelitis cases happened in Gaza. The massive contamination and delayed soft tissue coverage because of the mass casualties, the extensive bone tissue loss, and also because of mass casualty, again, most of the cases, 99% of the cases were treated with external fixation, whether it's monoplanar, biplanar, or ring fixator. So multi-drug resistant organism and the cross-infection risk happened. Hundreds of retained metallic shrapnel were difficult to remove, and they constitute a focus of the infection. And the injuries itself, the pattern of injuries itself used by the snipers were butterfly bullets. And you see this butterfly bullet destroy even the soft tissue, which constitute in the future a good envelope for vascularity and take the antibiotic to the area. So it was a disastrous condition. And still now, during the genocide in Gaza, still thousands of osteomyelitis cases. This is a photo here, for example, how the pin tracks we were encountering and the shrapnel. This is here anidus for infection, and this is here pin tract infection grade 6. Also, this here sequestrum, a case after removal of X6. We have a sequestrum, we have osteomyelitis here, local osteomyelitis. Development of antibiotic stewardship. It was not only orthopedic rule. It was orthopedic collaboration with antibiotic team or infectious disease team, physical therapy. Every day we did multidisciplinary meetings. This algorithm for example, how we reach this strategy came by time, and we implement it and send it to other hospitals, private hospitals. And the patient arrival and triage, if he came to our clinic, osteomyelitis clinic, if it's acute, less than 5 weeks, we deal with it as an acute osteomyelitis post-gunshot. We did negative pressure, weight bearing, and the blunt soft tissue coverage, either by flap or a graft and radical debridement. And for all the cases, we took 5 samples, 3 bone and 2 soft tissue. If the patient came after 5 weeks, we deal with this as a chronic osteomyelitis. We deal in the cases we discussed about amputation, but you know, they consider amputation as a stigma, and refuse. Most of the patients refused amputation, and most of those more ended after suffering with operation. They ended with amputation later. This is the algorithm also, but more detailed. For example, we take for chronic for more than 4 weeks. We applied Cherny-Madre classification. We did stage debridement, targeted culture, bone stabilization. For the bone defects less than 5 centimeters or 4 centimeters, I'm sorry, I wrote 5. We did debridement and culture-specific antibiotics until we did debridement until we reach a good paprika sign, and we did the muscular technique. We don't mix. Our strategy in MSF was don't mix cement with antibiotic. We were doing a very good debridement until we reach a healthy bone edges with good bleeding. So our targeted antibiotic can reach this healthy area. The bone defect, 5 to 7 centimeters, or diffuse osteomyelitis. We have a lack of curates in Gaza, lack of flexible reman. We were doing fenestration, like 10 centimeter fenestration in the bone, especially for cases of medullary debridement. And we did acute shortening for those cases. This fenestration for medullary osteomyelitis, it's written here by wrong. Okay, so in Gaza, the condition was horrible. Mass casualties of gunshots, acute osteomyelitis, chronic osteomyelitis cases, reconstruction units working. We don't have time for definitive fixation and limb salvage. The team who was dealing with those cases, the orthopedic surgery, the plastic surgery, the infectious disease surgery, microbiology lab, physiotherapy. There was special microbiology lab for those cases, only for osteomyelitis cases. And we did weekly stewardship meeting with antibiotics and antibiotic team, and multidisciplinary meeting every day. It was a great project before the last war in Gaza, and the service was implemented and be sure and limb reconstruction unit, another one in Nasser Hospital, has started working, but after that the big war came and everything is destroyed, unfortunately. Okay, we talked about this already. The strategy, debridement, plastic surgeon, and negative pressure wound therapy. If a flap was available to be done at the first session, it's okay. If not, we were planning it and doing negative pressure wound therapy. As you see here, this patient his flap was done in the first session of debridement by plastic surgeon, and we took the soft tissue cultures and bone cultures on a clean bed of debridement. Factors, the fixator used in Gaza cohort. Most of the cases in Gaza cohort osteomyelitis, and we still suffering till now, were treated by external fixators, any type. External fixator like monoplanar, Elizarov, PSF, LRS. We used LRS for cases of lengthening, destruction, osteogenesis, and also for cases of bone transport. And Elizarov also. PSF, we used it by support of MAB UK, Medical Aid for Palestinian Support Organization, and the reconstruction unit in Nasser Hospital. The sampling protocol, this was a brilliant methods we did in osteomyelitis project in Gaza, we were taking our samples separately. Every sample taken with a separate piece and was sent in a clean, for sure clean and sterile container. No sample were taken, no instrument used to take two samples. We took only for one instrument for one sample and then discarded. At the time of debridement, even the instruments we used them to take the samples, we discard them during the operation. We used another thing. The medullary debridement, we talk about fenestration. We did because we lack of flexible rebounds, requires for innovative techniques, cortical fenestrations, and then use the curates according to the size of our fenestration. We did fenestration by a maximum of to enable the curate, but we make it like a maximum of 1/4 of the circumference of the bone. So not to, the bone will not be weakened if this fenestration was long. And after the debridement of the medulla, we did washing of the medulla after the sample by 6 to 7 liters of normal saline, 6,000 milliliters at least. This we talked about it already, the acute shortening post-transport, amputation. Amputation we left it for diffuse osteomyelitis, and also still most of the patients were refusing. So they came along suppressing antibiotics. The key success factor of osteomyelitis unit in Nasser Hospital, we did daily multidisciplinary discussion and protocol refinement. Every day, the morning meeting was between orthopaedics, infectious disease, physical therapy, and psychosocial support also. We have a psychosocial support team, a great psychosocial support team. Whenever we wanted to discuss an application with the patients, we was discussing it. And collaboration between orthopedic plastic surgery. In any surgery of debridement, the plastic surgeon was there with us. He was planning for us where to put our pins, where to debride, which muscle we leave, which muscle we touch. So he has the future. He planned with us for his future surgery if the flap was a delayed flap. A strict isolation measure. After we found the cross infection, strict isolation measure we applied. I don't know him. Maybe they were treating osteomyelitis by themselves, but the radical debridement was the mainstay of treatment actually. We did a study in a cohort of 202 patients and 275 post-traumatic osteomyelitis episodes, because many of these patients having bilateral gunshots from December 2018 to December 2021. We follow up until 2022. 53% of the episodes were MDR cases, 43% with perimicrobial. Overall recurrence rate reaches 26% after 1 year. What were our definitions? What was the recurrence? What is the MDR? What is the contamination? The contamination was a positive bone biopsy that contains the following pathogens: coagulase negative staph or Cryonobacterium anthacillus, the MDR infection, drug-resistant bacterium that also has acquired non-susceptibility to at least one agent in three or more antimicrobial categories per corresponding antibiogram. Every patient has his own antibiogram, and recurrent infection is the relapse with the same strain or a new infection with different pathogen. A cure was declared at no relapse within 24 months. The microbiology profile in Gaza, through those two studies, we did two studies, one in Gaza alone, one in Gaza and Mosul Center in Iraq. The Staphylococcus aureus, the commonest, 35, even in chronic. 62% of Staph aureus isolates were MRSA, and Enterobacterales 13%, and 55.9 of enterobacteria were eatable producers. Pseudomonas, 10% of isolate. Risk factor for recurrence of our patients. Why is a recurrence sudden? More than 60 patients, we said 53% has relapsed. Up to 3, if in patients who did up to 3 previous surgical procedures. If a fibula, we noticed that the patient with fibula fractures included has the higher recurrence, maybe because of concentrated bacteria and because of the fibula, maybe. Enterobacter pulvica infection increased recurrence and probability in the patients with the Enterobacter pulvica association. They increased recurrence. The Staphylococcus aureus osteomyelitis was associated more with recurrence than other species. 6 months recurrence-free survival, 79%, but 2 years was 53 or 56. So the conflict and burden of osteomyelitis in Gaza, Great March of Return in 2018. All this we talk about is still before the last war. Now the mass casualty is great. We have tens of thousands of patients are still suffering, and they cannot cross the borders to go out to treatment. There is a bigger humanitarian medical crisis in Gaza, thousands of patients, and we ask all the world to support those patients to travel abroad to get the good treatment. The Great March of Return in 2018 caused more than 35,000 injuries in Gaza. MSF supported orthopedic units at Al-Awda Hospital and Nasser Hospital. Gaza patients proved significantly higher rates of violent trauma, multifragmented fractures. This was very bad fractures in our innocent patients. 92.7 of Gaza PAP2, Pseudomonas aeruginosa, post-traumatic osteomyelitis patients has a violent trauma injury. We noticed that Pseudomonas was more common in the patients with butterfly polyps. If this trauma was vigorous, I don't know why, but we did something called the PAP2 study. The PAP2 study about Pseudomonas aeruginosa, with as more the violent was the trauma, as more Pseudomonas aeruginosa association with the staff was. 100% of Gaza PAP2 fractures were multifragmentary. PAP2 is Pseudomonas aeruginosa, post-traumatic osteomyelitis. Okay. The PAP2 study was between Gaza and Mosul in Iraq. The osteomyelitis center in Iraq and Gaza osteomyelitis center. 46.7 of multi-drug resistant Pseudomonas were in Gaza. 74 were polymicrobial with association of Pseudomonas. 95 associated Staphylococcus with MRSA and Pseudomonas with it. Recurrence in PAP2 cases reached 24.6. This is the profile of antimicrobial resistance challenges in Gaza: ciprofloxacin, gentamicin, ceftazidime. Okay, this is our muscular bone grafting for the cases with defect less than from 4 to 6 centimeters. We used cement-induced membrane technique. We did replace the cement with only autograft. We didn't use bone substitutes. And sometimes if one iliac crest is not enough, we take it from the next iliac crest or the same side, from the posterior iliac crest, so the patient will not suffer pain at both sides. We took from anterior iliac crest and the posterior iliac crest. Why we didn't mix cement? We didn't mix our graft with any substitutes, either calcium sulfate or calcium phosphate or any bone substitutes. For most of the cases of muscular, we found a successful membrane at 6 weeks. We were implanting our graft at 5 to 6 weeks. Okay, we'll come to this one later. This is the bone transport cases we use. Bone transport in Gaza either by LRS or Elizarov technique or a TSF style special frame. This is a different case than the first. This is not the different case, this one. So successful bone transfer. This is the induced membrane technique, this case with a defect around 4 centimeters. We were doing our cement after radical debridement, taking one bone biopsy from the proximal end and one bone biopsy from the distal end, and one from medulla and one from soft tissue. We were intending to take our bone biopsies, and these biopsies at the end of our debridement. We take 3 before debridement and send them. And after that, we do our radical debridement and take another biopsy to check our margins. And we ensure to the lab, we have to ensure to the lab to separate, to do them in, to know this is before debridement and this is after debridement. So if the second biopsy after debridement, one of them was positive, we did another session of removal. We remove our cement, we debride again, and every biopsy has its site and a mark. For example, from the proximal cortex here, we did one, this is biopsy proximal cortex, we call it like this. So if the biopsy taken from here is still infected, have bacteria, we return back, we concentrated this area and debride more, and send also, and apply our cement again. We don't go for the second stage unless we are sure our debridement is very nice and the patient has no pathogen at the end of our debridement remaining. One of the challenges because of these injuries was the bad soft tissue envelope. Because of butterfly polyps, like the muscular technique in Gaza has not been very successful, actually, because most of the patients have bad envelope. We can say that 20% of cases of muscular technique has good success, and the others were dealt with better with acute shortening. Docking site problems encountered everywhere in the world. We sometimes inject bone marrow. This is the causes. Everyone, as a surgeon, knows it. Inject bone marrow, we debride again, and in the cases of bone transport, we faced docking site problems in all kinds of fixators. In all kinds of fixators, we use it. We did in Gaza thousands of fixators, thousands, more than you imagine. In reconstruction unit, in osteomyelitis unit, everything. Most of the cases, we didn't have time for definitive fixation. Most of the cases were challenging and very difficult. And for all of the cases, nearly 90% of the cases of bone transport, we encountered the docking site problems. Also, our unit has an admission criteria. Not any hospital transfer a patient, we receive it. We categorize our patients to, in 2 years, 1 year, first year, 1,200 patients reached us. Osteomyelitis, we categorize our patients, osteomyelitis, possible salvage, osteomyelitis, we can treat patients doing well, and the chargeable patient and amputation. I'm sorry, I'm taking a little 1 minute more. We talk about the MDT meeting. This is the profile, how we do our meeting. Here is the history, the ortho comment, the plastic comment, and the ID team comment. Here is the MDT plan for every patient. Were mentioned here. So we determine our the plan together. We determine our plan together. I have 2 more slides only. We determine our plan together and take the patient according to this plan. This file is a shared file. Was a shared file between all the teams, so everyone can check and see the plan for each patient, and what are the ortho notes, what are the plastic notes, what are the ID notes. Here it's mentioned everything. The bin track philosophy, we everywhere we could control them in Gaza by strict bin tract infection surveillance with extension. Even we did our special classification in Gaza, rather than check its classification was 6 grades, we created one with 4 grades. I will share it with you if you like. I will send it to Dr. Tispal. This is a muscular case, one muscular case. Unfortunately, this case ended with failure because the soft tissue here all was infected, and the culture was multi-drug resistant and very bad. How the studies we made between Ministry of Health and MSF changed the strategy of treating, of changing the treatment. The multi-drug resistance prevalence was very high. It reinformed strict isolation and antibiotic stewardship. After we found many cases, multi-drug resistance cases, we did isolation beds. In every unit was 80 beds of the bed, 80% of the beds were isolation beds actually. Pseudomonas resistance, this is an MSF unit. Pseudomonas resistant pattern changed the empirical and oral step-down strategies, and 43% polymicrobial infection justified progressive, aggressive deep sampling protocols. Recurrence data supported prolonged structured follow-up after to 24 months. And the MSF microbiology guided strategy, it was really great one, became central to Gaza limb salvage protocols, and we distributed it to all Gaza hospitals. And now in Gaza, we have the good experience to treat osteomyelitis, but you know the war, and you know the mass casualty, and you know the 10,000 of injuries. Okay, this is the organization collaborated in the project, which remains for 2 years. Unfortunately, we cry now. We don't have an implemented system for our patients. Maybe okay, orthopedic surgery team, plastic surgery team, it was a great. Okay, my key messages are important. We need support for Gaza, humanitarian and medical support by doctors, instruments, medicines, and help us to evacuate the thousands of patients, the occupation, preventing them from getting out of Gaza. This is, those patients need treatment, need management, and they should go out to be treated. So please help us. Send to your organization, to your medical facilities worldwide. We just want to treat our patients. We have thousands of patients, doesn't need beds, doesn't have beds, doesn't have definitive fixation, we have thousands of XFIX cases in Gaza needs a treatment outside. We have thousands of chronic osteomyelitis need treatment outside. We have thousands of cancer patients. Okay, it's impressive that this Gaza, the place that with those people, you see Gaza usually in the news as a war area, but it has produced internationally published a great studies about chronic osteomyelitis. We have a great doctors, we have a great teachers, we have a great systems, we have a great ambitions. But now, unfortunately, we need the help. This is the reference. This is my photo with my patients in 2021, some of my patients. I was used to talk to them, be friendly to them. Thank you very much. I am very sorry, Dr. Tispal. This presentation was long but important. I hope the message has reached you, and I hope our algorithm in Gaza will be acceptable or method to apply anywhere, and I'm welcome for any questions you want to ask. Thank you all very much.
Thank you very much. Thank you very much. Thank you very, very much, Dr. Seyam. It's not too easy to have such conferences in the online form, but you have made it excellent. Thank you very much. And we know that you have many problems, and we gave you some more time because of the difficulties that you have. Thank you very much. We have to continue with our Congress, and you can follow us over the WebEx or via YouTube. God bless you and thank you, my friend. Yeah, bye-bye.
Thank you. Thank you.
Also, the next one, dear colleagues, is Lorenzo from University Milano and speaks about explore the synovial fluid. What can we unveil to diagnose for PGA?
Yeah, thank you, Mohamed. Thank you, everybody. And I don't know how many laboratory specialists are present in this room. No one, I suppose. So it's the time to learn what you can ask to your lab and which decisional making you can do with the lab, how do you manage your sample, and so on. I think many of us participated to this international consensus meeting in Istanbul last time, and some important suggestions coming at that time, and especially the number of samples collected to improve the diagnosis, for instance, not more 3, 5, but maybe 4, 6. This is the first point. The second one is very, very important as microbiologist, just to avoid the number of false negatives that we have and you obtain and you get on the lab, is the day of incubation of your culture. All the scientific literature demonstrated clearly that it's necessary to take for 14 days your culture. Another important suggestion is the type of patients enrolled for the culture. All the patients under the revisions need to send the samples to your lab. And the last question is real important. We need to have just one test to identify positivity or negativity of your samples. Of course, yes, but still we do not have just one sample. So in your lab, you can ask many things. You can send many samples, blood samples for evaluating the CRP or the blood count. We will focus on the synovial fluid when we can ask many tests there, and it's necessary to understand which kind of test they change the rule or rule in or rule out your patient. Of course, tissue, biopsies, and prosthetic components are very, very important in that infection. What do we have in literature? We have these results. The high number of false positive, but especially the high number of false negative results. You have a clinical setting that doesn't match with the laboratory response. The pre-analytical phase in any lab when they received the samples is really important. Probably you have already heard about the sonication, just to dislodge the bacteria and to make very easily to isolate the microorganism in high amount. This is the secret of the sonication. Sonication has some pros and many cons, which is the rate of contamination. I don't know how many labs use sonication. Of course, it's very handling. It's not so easy for your lab to use it. They generally refuse to use sonication because it's really complicated. In Italy, we introduced this chemical compound called DTT, is dithiotretrol, able to do the same things that sonication. Is a chemical compound, is liquid, it doesn't need any equipments and so on, very easy and especially very inexpensive. Which are the results that we have in literature about the two methodology They are very comparable. We have very good results if you use sonication as well as we use DTT. And this is a very, very good results. But try to focus about the very important sample that sometimes you collect and you send on the laboratory once that you want to discover if the patient has an infection or not. This is the synovial fluid. As you know, the synovial fluid is really important, but we need to take in account that the synovial fluid nowadays is not does not give just a right response if you use it in a wrong way. Firstly, we don't have only one test, especially, of course, you have heard how many biomarkers you can use inside the synovial fluid, but the biomarkers we need to consider as an adjunct test and not because there is no one test giving the right response. For instance, we need to know that we have several definitions about the parameters that you use just to give a positivity or not of your synovial fluid. Of course, it's important to know if the infection is chronic. It's important to know if the infection is acute, because can change the cutoff of many parameters that your lab use. ABJS, for instance, introduced a novelty about that, introduced probably if we use another cutoff, we can start just an alert situation just to decide if your patient is infected or not. It's not so easy, honestly, to understand that to give a fixed parameter just to decide if your patient is infected or not. There are other biomarkers that you for sure have already heard, is the leukocyte esterase. Leukocyte esterase is a very inexpensive marker, very useful marker, but your lab need to use in a very, very way. When you send to the lab synovial fluid with an high amount of red blood cells, is useless to send that sample because they can not be used to test leukocyte esterase because this sample can give a lot of false positive. If even alpha defensin, we need to decide which kind of test. You have to know that we have two types of tests. One is the flow lateral test. That's very easy to use. Instead, the lab used the ELISA test. Of course, the proficiency of the ELISA is much more higher than the flow lateral test. Calprotectin, another interesting biomarker, now is relatively new. We are trying to establish a cutoff, the right cutoff to say yes, is quite positive or not. We have other biomarkers, synovial, CRP, interleukin-6, lactate, and so on. But we need to consider these additional tests as adjunct tests and not as single tests. This is the overall situation related to specificity and the sensibility. This is a very new revision of literature. It's really interesting to say that all the tests that we describe in the literature, they have a very high sensitivity and very high specificity. But the revision underline one important thing, that the substantial heterogeneity and the risk of bias in patient selection, reference standards, and the threshold used is very, very high. And this is the main problem. The main problem that we have as laboratoricians and you as clinical, that probably we don't chat each other. We don't talk each other to understand the clinical situation in the laboratory answer. We have a lot of false positive in all the tests that we used and I mentioned before. Probably you know, in case of metallosis, of course, in cases of other inflammatory disease, in case of bloody or hemorrhagic types of synovial fluid, or recent surgery or sterile inflammation can give fast positive results. This is really important. There is one important topic that I would like to stress and focus today before to finish is the pre-analytical phase. How to collect the sample, how to transport the sample, how to handle the sample, and which type of pre-analytical phase you can suggest to do to your lab. It's really, really important as you to see. Of course, microbiology, as we have heard in the previous presentation, is very important. They represent the landmarks of the positivity and the negativity. Of course, if you have germs, you can say is positive, but if you don't have germ, this doesn't mean that is negative, because probably something can happen in the used sample before to be processed by the U or tested in the laboratory. So synovial fluid is really important and become more important if it is combined with other samples, biopsies, component hardwares. It's really important. We cannot consider only one test, one sample to judge or to define if you are positive or negative. Prolonged incubation is really important. In many samples now, not only in the shoulder, we have other germs that we have faced in the past, not only staphylococci, not only streptococci, but we have other germs like Cutibacteria acnes even in the hip and even in the knees. That's why we need to prolong incubation. This is a brief presentation and what we read in literature. But when we face with the reality, what can happen? When we face with this type of patient, we are happy because the clinical setting corresponds exactly to the clinical response. All the parameters have a perfect correspondence. So the parameters are very high. We isolate microorganisms. It's very, very easy, and we are happy when we face with this type of patient. But many times we face with this kind of patient where some biomarkers are negative. The leukocyte hysteresis poorly positive, or the frozen section, one is positive, one is negative, or the synovial fluid is again negative, but only one of the 7 samples that we have sent to the laboratory is positive. What we can do in this case? What we can decide for that patient? I think it's real important how to treat, and especially how to pre-treat the sample, and especially how we treat and observe and pre-treat the synovial sample. You have to know that even not only in the prosthetic components, but also in the tissues, and especially in liquids, we have the biofilms. Which is the meaning of the presence of the biofilm in the liquid, and especially in the synovial fluid. This is old literature, only 10 years, when this author demonstrated the presence of biofilm in the blood, in the serum, and also in the synovial fluid. And we started to think in a different way how to pre-treat, how to consider the synovial fluid and any fluid that we collect and achieves the laboratory. And we hypothesized that probably if the bacteria are endowed, are enclosed inside the biofilm, probably they are not so evident in the culture and in the laboratory work. So it means that when the aggregates of many, many bacteria are few, probably we have a high probability to have a negative sample. But when the aggregates, for instance, can be dissolved, we can release much more bacteria, and probably we increase the positivity. This was the first hypothesis that we had in 4 years ago, and luckily we have demonstrated this in this particular paper, and we demonstrated that there is an increase of sensitivity of those samples when the aggregates existed and when the aggregates are very, very high. Because when you pick up the liquid, you can pick up, if you are lucky, some aggregates. But if you are not lucky, you can pick up only the liquid, sterile liquid without bacteria. And we clearly demonstrated that with this was, we evidenced on the synovial fluid, where we demonstrated this in this confocal microscopy, that there are some aggregates. Of course, if you pick up your liquid when there are no aggregates, the sample is negative. This is the simple situation. In reality, we made another experiment at that time that we tried to dislodge the bacteria to dissolve these aggregates by using DDT, the chemical substance able to dissolve these aggregates. And these were the results that we obtained, was fantastic. Dissolving the bacteria, we increased the possibility to pick up the liquid with bacteria. And these are some pictures of the bacterial counts that we obtain in many, many synovial samples. It means that we increase the positivity and we decrease the false negativity in at least 30% of the samples. I continue my experience with another liquid, which is the urine. Urine culture is really, really important, and we clearly demonstrated that in this recent published paper that even in the urine we have co-aggregates. Even in the urine, if we dissolve these co-aggregates with DDT, we increase the possibility to have just a positive and to establish the right cutoff of the urinal culture. So another, and this is the last point that I would like to clarify, is the use, the modern era of microbiology called molecular testing and especially next generation sequencing testing. It's necessary to clarify for the orthopedics, for the clinicians, that any test, molecular test, doesn't give a complete grade of antibiotic susceptibility. It means that they can give just, we have a gene giving that antimicrobial resistance, but we don't have the grade of that resistance. The MIC that we measure has a meaning, and the meaning is that the value of a MIC reflects how much drug we can use, the type of resistance, and the level of resistance if the MIC is high. Having a gene doesn't mean that they bacteria express in the reality, in true life, the gene. Of course, can be used in case of false negative or negative results when the clinical setting is really suggestive to give, to say, yes, the patient, I have a high suspicion that the patient is positive. Why is negative? You can ask to use this technique. There is another problem when we use this platform, this molecular platform. And the problem is, again, the patient and the type of the patient, the type of the samples, the type of microorganism, that because they can give different results on the type of the sample that we are using, the time of transportation, the preclinical setting. So you can understand how much we can do just to definitively diagnose a prostatic or a joint infection. Some important message, just to repeat what I said, there is no single synovial test, I'm sorry for that, giving the true positive or the true negative. Probably it's necessary to combine a right algorithm of several tests to give a definitive answer. We can have a lot of false positive results, as well as we can have a lot of false negative results. Of course, the culture, the microbial culture, still remain the gold standard in this case, and probably in one future it is important to use some pre-analytical, a specific pre-analytical phase on that sample that you can suggest to your lab how to do and how to do the best before to have the definitive diagnosis. Thank you so much.
Thank you, dear Lorenzo. Fantastic presentation. The next presentation, ladies and gentlemen, is from Dr. Salva from the University, Knappschaft University Hospital in Bochum, in the near of hospital. Septic failure after one-stage exchange for prostatic joint infection of the hip, microbiological implications.
Okay, hier unten, da? Delay. Thank you very much. Good afternoon, and I would like to thank the organizer, Professor Tesfal, for inviting me. So today I would like to present one of our multiple works about a septic failure after one-stage exchange for prosthetic joint infection of the hip, and what we can learn out of it for microbiological implications. So I have nothing to disclose. The background, why this topic matters, one-stage exchange is effective, but when it fails, the consequences are severe. So therefore, understanding why it fails is essential for surgical strategy, diagnostics, and follow-up. So we all know that one-stage exchange increasingly adopted worldwide. High infection-free survival is around about 94% at 10 years, but septic failures still occur and are surgically demanding. Microbiological patterns after failure remain poorly understood, and the key question we have to ask ourselves is it a more persistent problem, or is it a real reinfection? So our study design was as follows. We made a retrospective cohort study together with the Endo Clinic in Hamburg. We included 77 patients with septic failure after one-stage hip exchange, and all patients were from the period 2001 to 2017. And we had the paired microbiology. That means we had cultures from before one-stage exchange and at the failure time point. Mean time to failure was 1.7 years in a range of 0 to round about 12. So first of all, I would like to address your attention to the baseline microbiology. We saw 26 different microorganisms, or we identified 26 different microorganisms. Most commonly, we had Staphylococcus epidermidis in 31 patients, Staphylococcus aureus in 23, Cutibacterium agnus, formerly known as Propionibacterium, with 12, and Staphylococcus capitis with 11. And we had in 30% of the cases polymicrobial infections and no PCR used pre-operatively. So what was our key finding? So the differentiation between persistent versus reinfection. What we found were 55% completely new microorganisms that were 42 patients out of 77. So we call them pure reinfections. We had 31% identical pathogens. That means 24 patients out of 77. So they were real persistent infections, and 15% additional pathogens. So 11 patients out of 77, and we call them hybrid infections. The interpretation is very clear: reinfection domains. The clinical message is therefore, do not rely on historical cultures. So reinfection dominates, therefore every failure requires a full diagnostic reset. What can we say about the polymicrobial trends? So significant decrease in polymicrobial PJIs we could find. We had 13% shifted from mono to polymicrobial, but 27% shifted from poly to monomicrobial. So there was no evidence that failures become more complex microbiologically. So therefore, the clear message from this study is polymicrobial failures do not increase, contradicting the assumption that one-stage failures are microbiologically more complex. What could we find, or what can we say to the virulence spectrum? Is there a virulence shift? What we could find in this study was high virulent organisms decreased from 52 to 36 significantly. Low virulent organisms increased. Late failures, that means over 1 year, were often high virulent, and that suggests at the end that we have here to deal with exogenous reinfection. So late high virulent reinfection often originate from everyday infection sources everyone can suffer from, even healthy patients. That means pneumonia, urinary tract infections, and particularly periodontal diseases. Patients with extensive implanted biomaterials, and this is very important. Patients cannot only have one implant, for instance, knee or hip, and this is already a lot of foreign material within us. They can even have shoulder, two knees, hip, knee, and shoulder, and so on. This we have to keep in mind. This is a lot of foreign material in our body, And particularly patients with such an amount of foreign material represent a uniquely vulnerable population, because any transient bacteremia later on, can seed foreign materials. This underscores the need for implant surfaces that resist bacterial adhesion and biofilm formation. And it's really unclear, particularly for me as biomaterial scientist and bioengineer and orthopedic surgeon, that particularly into this direction is very, very low progress currently. Difficult to treat bacteria. So we saw that gram-negative infections stay stable, round about from 11 to 14. Difficult to treat pathogens, we saw an increase from 16 to 22, but this was not significant. And one important finding was that rifampicin-resistant staphylococci increased from 8 to 15 patients in this cohort. So our interpretation was no major shift toward resistant organisms, but the vigilance is needed here. So the rise in rifampicin-resistant staphylococci likely reflects prior antibiotic exposures, not a shift in pathogen ecology. So what can we say about the diagnostic detectability? In only 2 cases, we had difficulties to diagnose. There was 1 culture negative and 1 PCR positive. And therefore, we decided to double the open biopsies from 7 to 14. So this is a regimen in the endoclinic for such cases. So the message, or our message, is finally, failures are detectable, but require aggressive diagnostics. And this fits very good to my previous presenter. One-stage failure is not a diagnostic black box, but it requires a lower threshold for invasive sampling. So, timing to failure. So we saw that 90% failure was analyzed within 3 months, 56% within 1 year, but also 44% after 1 year. So the implication is ICM1, so International Consensus Meeting, 1 year follow-up is insufficient, and our recommendation is that we need to consider more than 2 years structured follow-up. Clinical consequences are finally always perform full diagnostic workflow at failure. Reinfection is likely, avoid relying on old cultures. Consider broader and longer antibiotics in selected cases, and the treatment decisions should prioritize host and implant factors. Extend follow-up should go to 24 months. Treat the host and the implant, not the historical microbiology. My take-home message are, or our key take-home messages are, reinfection is more common than persistence after one stage exchange. Microbiology does not become more resistant or more complex, but it changes. Diagnostics must be repeated and follow-up must be extended. Host and implant factors drive decision-making more than pathogen identity. Patients with extensive implanted biomaterials are highly vulnerable to hematogenous seeding. So everyday infections can colonize foreign surfaces. One-stage exchange remains effective, but failures require a new diagnostic lens. So finally, I would like to acknowledge my team, Dirk Grun, Professor Andreas Schnitzbauer, our clinic boss, Dr. Alexander Sieberet, one of my postdocs, Charlotte de Tembele, she is from the clinic, Anna Wille and Zoya Ilyana, both made her master thesis under my supervision. And I would like to thank my friend and meanwhile colleague within the Knappschaft Kliniken community, Professor Mustafa Shitak. We did a lot in the past 20 years together, and meanwhile we are working together, and this is very good. And we founded the Chosen Ones. This is a group of 48 orthopedic surgeons working on such publications and studies and so on. And at the end, if you have further questions, collaborations, or consultations, here are my data, and you can call me or write me at any time you like. Thank you very much.
Thank you very much. Thank you very much, Dr. Salva. The very nice aspect of the PGI. Then the last presentation for this session is from Privatdozent Dr. Pieske from University of Oldenburg. Yes. And he will speak about orthoplastic management. Dear colleagues, you have seen many lectures about combination and usefulness from the plastic surgery and orthopedic surgery. And that is a very, very interesting and very necessary concept. And the colleagues try to explain this concept. Oli.
Yeah, before I want to start with the talk, I want to point out 3 things. The first thing is, thank you for invitation. The second thing is, wonderful organization with sun outside, technique perfectly up to Gaza, incredible work, wonderful. And the third thing is that I would say we have to continue with this worldwide, international, and we have to work on in Germany also to establish this more and more. And I know from a lot of colleagues also from Germany who wanted to be here, like Ferg von Lübken and so on, who have been last year in Westerstede. And but I want also to say greetings from my colleague. 20 years I worked together with Professor Lob, and he can't be here with us, but I think he would be very keen to be with us today. Now we want to start with our talk, and you can see that we are 2 persons here.
As we work every day.
And
can you?
I am the orthopedic surgeon, and he will explain who he will be. My name is Oliver Pieske. I'm coming from Oldenburg, and Oldenburg is in the northern part of Germany. It's also a medical university town. And now probably you want to introduce yourself.
I'm Lucian Giga. I'm chief of the Department of Plastic Reconstructive Hand Surgery in the same hospital together with Oliver. And I'm very happy to be here today because I'm a reconstructive microsurgeon and I'm part of an orthopaedic congress, and this is due to our very nice cooperation that we are nurturing for many years. And in this presentation, we would like to give you an insight on how we think about managing complex cases requiring orthoplastic surgery. Should I? Yeah, thank you. I'll try to use this. So what is the orthoplastic approach in regards of lower limb trauma? This is a kind of multidisciplinary way of thinking when you deal with major defects involving both bone and soft tissue. And in the end, it has everything to do with extremity salvage, right? We have seen here fantastic talks on actually colleagues that I could name heroes working and dealing in Gaza or in other hospitals in other parts of the world with crazy defects involving both bone, infected bone, loss of soft tissue, and trying to manage those extremities so they will not be amputated. And of course, we are talking about these people that instead of being amputated, they will get to keep their legs, so an improvement in the quality of life. Talking about the definition of the orthoplastic concept, actually we can be very proud about Professor Lexa that it was 1900s that he already thought about managing soft tissues in the same way he thought about managing open fractures in terms of increasing the salvage rate of lower extremities. And of course, especially from the plastic surgery point of view, we need to mention Marko Godina, a Slovenian plastic reconstructive surgeon that has actually put on the map the concept of very early soft tissue coverage when dealing with open fractures like with infected bone, and was able to publish the first publication, which I will give you an insight in, showing that the sooner you are covering the exposed bone with free flaps, the better would be for that extremity and the lower the infection rate. Of course, Dr. Scott Levin is another name that needs to be and will remain related with the concept of orthoplastic surgery in the history. He's a very famous orthopedic plastic surgeon in the United States that promoted the orthoplastic surgery concept throughout the world and still does. So this is the publication of Marco Godina, and I would like you to concentrate on those two columns, early and delayed. He's talking there about early and delayed reconstruction, and if you're looking at the number of complications and the number of infections, you can see if you're doing, for example, an early free flap coverage in a group of patients, if you compare them with the delayed free flap coverage, you see the number of infections, the number of complications increase exponentially, and this is what he actually promoted that back then. But if let's look, this was very many years ago. Let's look now in the modern times. You see that actually his concepts are still valid. However, you can read in the conclusion part of this paper that was published by the group of Professor Levin that these patients should be, so the principles are the same, but dealing with these complex situations should be done in centers that are specialized, and they have really the expertise from the orthopedic, from the plastic, from the microbiology, from the laboratory, from the intensive care possibilities to successfully save these extremities.
Now coming from theory to practical things, this is the real life we see in our trauma centers, level A. One in Oldenburg, and this guy had contact with a train, so you can see he has multiple traumas, and one of this is of course the one in the lower limb, which is predominant, and of course this needs, let's say, really a unique and a treatment not only from the trauma surgeon, but from a lot of surgeons, probably from vessel surgeons, from plastic surgeons, and so on, but also later on, as we heard before, the antibioticum steroid, the physiotherapy, all these had to be integrated to treat these people correctly. And just to give you a short operation, but we have seen a lot already in the talks before. Be the first in the OR, make a radical debridement, stabilize the bone, revascularize, soft tissue must be evaluated, and then probably spare parts banking and early soft tissue and bone reconstruction, and of course in lower extremity always prevent equinus contracture. And of course in these types of injuries we have to think always, is reconstruction a good idea? Because everybody knows it takes a lot of time, a lot of money, and what is the result at the end? And we have to discuss really hard in these cases whether amputation might be the better solution, the really better solution for the patient. And we have this MES score. Everybody knows, I think, this paper 1990. And yes, in these times they say 100% if the MES score is over 7, you should do the procedure, but
there are other scores, many of them, that actually evaluated the same thing, whether to amputate or to preserve an extremity that has been massively injured. And the question in the end is, should we always use these scores as a reference when we have our patients in the emergency bay area and decide, even interdisciplinary, whether to amputate or to salvage the limb? And I think the scores are good. So everybody knows that if you have a massive trauma with loss of nerve, loss of bone, loss of soft tissue, even if you reconstruct, this patient would have years and years of prolonged sufferance because they will not be able to use their legs, even if you are able to save them. So in the end, the idea is that those scores are okay in terms of knowing about them, in terms of applying them, but not in terms of having the final decision whether to amputate or reconstruct. And these scores should not be the sole criterion for evaluation of this type of injuries. And this is actually a publication that in the end, if you read it, you will see that these scores have a rather high sensitivity, like the MES score, but a very low specificity. So what is the message? These scores should not be the sole criterion when you evaluate, and this is very important. I'm telling this from the second time in a second consecutive slide, but I think it's very important because we have talked all the day about infections, about chronic wounds, about this type of lower extremity trauma. So it's important not to have these scores as the main tool in your hand to decide whether to salvage or to amputate. And there is another very important thing. We should not forget that we are at this time, we have evolved that much in terms of prosthetics. We have the biomechanical prosthetics. We have really prostheses with which people can live more or less aside from the psychological trauma of normal life. And this is actually, this slide is self-explanatory. This is a paper of Dr. Levin that talks about the respective roles of plastic and orthopedic surgery in limb salvage. And he is also undermining the fact that when the prosthesis will become better than us surgeons, prosthesis will be the way to go when we lose an extremity, because this will enable us to lead a much fuller and much healthier life.
Now we want to go through a few cases with you, and this you can see is a quite dislocated fracture of the lower limb. The pilon is also included, and just to give you, we won't talk about all these now, but just to give you what we have done, operated and stabilized, but you can see there might be a problem at the medial wound. Next type is a bicycle driver, 50 years old, around contact with a truck, and this dislocation is a knee joint, and you can see there's also an injury of the vessels, and there's a huge destroyment and also a dislocation of the joint face, and you can see that on the right side that we did a lot of operation, but we will show you later on the results. And the last case here in this area now is operated open fracture of the tibia, and also here you can see there's a wound problem and what we have done at the end. Now,
change again. So these are actually the principles of orthoplastics. I will not insist on them because everybody doing orthopedic, reconstructive surgery and lower extremity knows about them. I will insist again about the fact that each of us in the 21st century, having in the hand both the reconstructive and the orthopedic science, should take each patient separately and try to decide according to each patient, according to each wound, according to each situation, whether to reconstruct or amputate. This is why we have created, this is not something new, the so-called Interdisciplinary Extremity Board. This is a place where orthopedics, plastics, vascular, radiologists, microbiologists, physiotherapists come together and decide not only about the surgical steps that a certain patient needs to undergo in order to save an extremity or amputate, but also about the long-term follow-up, about post-operative care, rehabilitation, because this is actually has almost the same importance as the surgery. For the ones of you doing hand and wrist surgery, you know how important the post-operative therapy is. So there are in Germany already several approaches in the same direction, and these are some publications undermining, again, the role of the orthoplastic cooperation in terms of lower extremity salvage. Not only lower extremity, we are talking here not only about trauma, we can talk here about sarcoma surgery and about different other problems which leave patients incapacitated. So
we can see here a map, and you can see this is the northern part of Germany with Hamburg, with Kiel, and so on. And we are just on the western part, and we just started in January to build this interdisciplinary cooperation. If we haven't done this, you can see that there is a huge area without any center to do this. But I think it is like in the trauma level A center and so on, you have to have some centers where you come with these cases together and you have a specialist who can treat these things. But in our case, we have a special situation. We have divided. We are not in the same unit. We don't have the same capacity of OR. We don't have the same capacity of other doctors. We are divided. So we have now to step together while we are standing also a kind of friends, because we want to have the same aim fulfilled to help the patient. And we had to go to our, let's say, clinical department chiefs to say, okay, we want to do this. And now, of course, sometimes it's also a kind of money question, because the financial department say, hey, you have to do the work, and no, he say, you have to do this. But we say, no, we divide 50-50. One, if you treat together, we make 50-50, we start with this. But you have to write it. You have to fix it. You have to start with something where you can rely on it. And don't make it too complicated. The second thing is, make all your dates all the year. Every 2 weeks, you go together with your cases. Sometimes, of course, you have more cases, you do it weekly, but every 2 weeks, fixed date and completely arranged. Everything is who will be part of and so on. Every question must be answered before. And second thing is, if you are thinking that you have a huge, let's say, area you want to serve, then you should also put in your mind to bring telemedicine. And we are offering this already, but also you have in Germany, of course, you have to go for data protection. So also do this with your departments of who can help you to do this correctly. Yes. Okay, now coming back to this case, you can see we have done a lot of metal to bring this fracture in a correct position. And I think the fracture is good operated, but
like Oliver told you, you see, these are the wounds that were coming from the open fracture, and of course the surgical approach wounds in order to fix the bone. So looking at the wounds and knowing the anatomy and the angiosomes of the skin in the lower extremity, like ankle and foot, you see that there are some not nice intersections which could not be, however, avoided by the operating orthopedic surgeons, so in order to fix the bone. So in the end, you have a very nice metal job, but the problem is one of the wounds is breaking down, and directly underneath that wound is the metal that was just placed in order to stabilize the fracture. So you go, this is one of the things that you nurture within this cooperation, is that the orthopedic surgeons comes to me and tells me, look, there might be a problem, we should keep an eye on this patient. And just this communication alone provides the patient a chance not to develop chronic osteomyelitis, not to have been forced to be placed on external fixation, metal out, treating infection, treating bone loss, and so on. So this is the debridement, okay? And I will not talk about debridement, because per definition, debridement is not what we do here. What we do here is a radical excision of all tissues that are dead. Okay, so, you know, everything that's dead comes away, and then we have to deal with the defect, which looks like that. Talking about possible flaps or techniques we have to reconstruct this wound is probably thematic for another talk. But here you have a lower leg, you don't have much of soft tissue left. This was a crush injury, so the lateral side of the ankle and the foot are already scarred. So this is why we do in these cases, we do a free flap. In this case, this was a perfecta flap, anterolateral thigh flap. And the patient could leave 5-6 days after this surgery the hospital with a clear wound that is now healing.
Yeah, now you can see here the second case. We have seen this picture already, and you could see the same procedure has to be performed, put out all these soft tissue, which is necrotic and not vital, and then again cooperate.
Then again cooperate, and for me it's not enough. I could not stress this enough. We are developing here a culture, and through this culture, in this case, my colleague, the orthopedic surgeon, had made his last visit to the patient before he was to be discharged. And this was the moment where I got the call. He told me, look, actually, he's with one foot out of the hospital, but this one does not look okay. So, of course, you have already seen in Oliver's slide that once we took out, he told me, below this necrotic skin, there's only plate and bone. There's no soft tissue left. So I would not let him go. Please do something. And of course, from the plastic surgery point of view, this is a rather straightforward procedure where you put a flap on it. And with the flap, you solve the problem. And the patient, of course, spent another week in the hospital, but now he's safe home with a bone that, again, can heal under this new vascularized tissue that was brought in this wound.
And this is just another extra case. It was an open fracture. You can see there's a bone part anteriorly flipped out and addressed with 2 screws and a nail. And we put some bone morphogenic protein inside, but at the end there was also this, let's say, huge defect of soft tissue at the end.
So this is why we actually love to cooperate, because I can give the orthopedic surgeon the freedom to do his surgery the best way he thinks he can do it without thinking about soft tissues, even if you have a complex problem. And this being said, again, this is a case where from the plastic reconstructive surgery point of view, there is no major challenge there. Of course, you need to have this microsurgical expertise, the team, and everything else that refers to this type of very special procedures. But for us was after Oli and his team did their job with the bone fixation, we just put a flap on it. And that, yeah. And then this is actually the end. I think it's very important to say that this patient also got in the end a derotational osteotomy. Du kannst, glaube ich, damit und guckst hier.
Ah, okay. Well, probably you can see it here. So we made here just the cut, and we turned it and made a new Verriegelung.
So if you click now, maybe the movie will, yeah. So this is the patient 6 months after surgery. Actually, yeah, went back to her very nice life. Okay.
So yeah, and this is the case we have seen before already. And now the question was, of course, reconstruct and fix first and so on, do a lot of metal things.
So this case, actually, as you see, was actually a Gustilo 3C. So the problem was not only the bone damage and the soft tissue damage, but also a ruptured popliteal artery, which needed to be acutely reconstructed in order to save the leg. And this is actually the picture you see here is after we have reconstructed the popliteal artery in emergency, patient developed, of course, the compartment. So through the compartment and through the crush injury, he lost the skin over the bone job. He still had, of course, a patent main vascular access that kept his foot alive. But what do you do with this one, which is already, of course, infected? You have plates inside. Orthopedics actually did their perfect job. You can see actually on here, this is an interpositional graph we did in the middle and the second part of the popliteal artery in order to reconstruct. And what do you do with this case? I mean, this was a very sporty a guy that didn't accept the idea that someone would amputate his leg, even if you are in front of this devastating injury. So this is also from the plastic reconstructive surgery point of view a little bit more challenging. Why? Because of course you need free tissue transfer. For this you need recipient vessels in order to hook up your flap. So where would you look for recipient vessels knowing that the popliteal artery was already reconstructed, right? So there comes the magic, reconstructive surgery. We are able to provide for ourselves. What do I mean by that? We are able to reconstruct our future recipient vessels and place them there where we want it. So here in this case, what we have done, actually we did a so-called vascular loop. I went in the Hunter canal, so we are in the thigh here, and this is the saphenous vein, the gray saphenous vein from the other leg, which we anastomose proximally to the superficial femoral artery and vein. And then we have tunneled the graft distal to the wound. So we had, in that moment, created a new vein, an artery, where we should, we could very easily hook up the flap. This was a bigger flap, in this case a muscle flap, actually a kind of a chimeric flap. This is latissimus dorsi with the serratus anterior. Why? Because you need lots of volume, new tissue that will cover this wound. And this is the early postoperative stage where the flap luckily survived. And this is afterwards. This is one of the pictures we got from this patient about 8 months after the surgery.
And despite the fact that we have a lot of, let's say, material, and also, to be honest, the joint line is not very, very, very nice in this case. But to make a long story short,
this is the end result. So to the left, to your left, you see where we have started. And this is the patient actually being able to ambulate again. It's not a perfect way of walking, but he's driving his bike again.
That's the most important point for him, to do his sport again. Okay, so let's go for summary. Act fast, yeah. First slot in OR. Think about amputation. Not always reconstruction is the best, but try your best and do the interdisciplinary work.
Yes, and we come to an end where we actually can only recommend everybody that working in this realm of orthoplastic trauma surgery and has near him a plastic surgeon to try to bind in this relationship and actually establish an interdisciplinary orthoplastic extremity board. It helped us a lot. It helped nourish our relationship as surgeons, and in the end, we look forward to a big future with this extremity board. Thank you so much.
Dear Oli, dear Dr. Jiggle, fantastic concept. This is not any compromising. That is the concept. That is a cooperative. Yeah. And the financial details is important, especially in Germany. Dear colleagues, dear friends, I think it's now a time to have a lunch, and we try to have a photo from our group outside, but I think we can go to lunch for first. Thank you very much. Till now.
Ja, ja, ist wichtig, natürlich, wenn Sie am Ball bleiben.
Ich gehe jetzt heute Nachmittag auch nicht. 19 Uhr aufgehe ich auch.
Auch Herr Skala, wenn fertig ist, muss auch so ein bisschen schwimmen. Jawohl. So, my dear friends, excuse me for the time. I have tried to be relaxed. I have tried to give more time, not the typical time management and arrangement of intensive congresses. We gave the colleagues time to speak and to talk and to analyze. And till now we have had very nice lectures from Gaza, from Italy, from North Germany, around the world. And we have in the last years, we have seen the many lectures, not only here, but also in Egypt, in Germany, in America, about surgery. Surgery, physician, successful surgeon, fantastic pictures, heroes, orthopedic surgeon, yes, but we have tried to see the problem from the view of the patient. How was the life of patient in this time? And I'm very happy, ich danke Ihnen, welcome, say to Frau Voss and Herr Scarlett, two patients from our hospital, inpatient care after osteomyelitis. It's not important what was the reason and what was the initial trauma. For example, Ms. Voss had a complex tibial fracture after complex reconstruction, and she was 3 months after, ich erzähle diese Parkplatzgeschichte, 3 months after discharge, we thought, is everything okay? And I see her zufällig, yeah, accidentally, at the park house in our second hospital. I go and I say, oh, Frau Voss, hello, how are you? Fantastic, she said. Fantastic, fantastic, oh, fantastic results. I'm very happy about this, sehr froh. She said, but just a little thing is not very good. What? After 3 months, after the surgery? Here is just a little fistel, just a little hole. Oh, no. And I said to her, just a minute, Frau Voss, please come back to the hospital.
Ja.
At the parking. Yes.
Auf dem Parkplatz. Hat er mich in die Hand genommen.
You were in our staff, yes, in doctor resident. Resident, after 3 months, is the wound, is everything okay? No. 3 months after the surgery, the fistel is sick. After a long time, yeah, and the procedure with debridement, multiple operations, and reconstruction, and we have, yes, we can say, after, wie lange haben wir jetzt hinter uns, nach der letzten OP? After?
Weihnachten 24.
Yeah, 2 years, she makes sport, is happy, she's very active. Mr. Scarlett, in a foreign hospital outside of Germany, operated on the leg with plate osteocentesis after a fracture of the tibia. The complex fracture was operated, was okay, but he had a non-union. And We have in our hospital the school of two-stage diagnostic, probe, septic, remove of the metal, and the other procedure like fixator, debridement, antibiotic, and all of that what we explained today here. And we have a fluid infection developed in his case, and after the successful removal of the treatment of the infection, we began with Ilizarov. And after 4, 5, 6 months, is removed the device, and we have decided to have a weight bearing for him. And he is in the phase where the wounds is okay, it's dry, and they try to have a weight bearing. It's naturally that the pain and he's not so active and so mobile like before the surgery. It's okay, but I think he will be mobile approximately after from now 4 to 8 weeks. I think, and we see to the healing of the bone, Carlos. We are happy about this, but they wish to answer in German, and I ask the people, how was the time? Please explain how was the time for you, for her and for him. First, thank you very much for coming. The first is, how was your reaction deep in the heart as you heard about the unsuccessful surgery or infection? Was haben Sie gefühlt, als Sie gehört haben, dass es doch ein Infekt ist? Ja? Wie haben Sie sich gefühlt?
Ja, eher schlecht als recht. Ne? Ich habe gedacht, die Sache wäre damit gegessen, aber wir haben ja das war ja erstmal der Anfang von dem ganzen Theater, was ich da vor mir hatte.
She said, thought that she has all the pains and device and surgeries behind her, and she can make sport and another thing. Sie können Sport machen, wahrscheinlich dachten sie, but it came wie eine Bombe, ja, like a bomb. Yes, we have to remove, the device, and we need another surgery. Und danach, wir haben gesagt, wir müssen durch, wir haben keine andere Wahl, das ist nur any alternative. We need it. Und was war besonders in den ersten Wochen, in the first weeks after the surgery, after the revision surgery, how was this time for you? Wie war die Zeit für Sie?
Ja, erstmal lange. Es war ja sehr lange, dass ich da bei euch war. Ja, und ich habe immer gedacht, das kommt nie wieder in Ordnung. Ne? Ich werde nie wieder laufen können, ich werde nie wieder arbeiten können. Sport, ne? Also meine ganze Freizeitgeschichte würde dabei auf der Strecke bleiben, was aber nicht ist.
She thought at this time that is the end of mobility of her. That's the end of sport, end of mobility. That is not the end of the life, but end of all mobility and activities from it. She is a very active person. Und irgendwann wurden sie operiert, das hat lange gedauert. Welche soziale Probleme hatten Sie? Alles, was Sie meinen, was ich meine. Von zu Hause gesehen, Umgebung, Fahren, Arzt, Physio. I ask, what is with the social problems during this time for you?
Ja, also erstmal das Problem, immer wieder hierher zu kommen, zur Untersuchung. Ich musste immer jemand haben, der mich hin und her fährt.
Alone to find person to bring her to the hospital, sometimes is very difficult.
Ja, und zu Hause, muss ich sagen, habe ich meine Familie, meine Kinder, meinen Mann, die mir wirklich immer zur Seite gestanden haben und die haben alles für mich gemacht. Also da bin ich ganz gut aufgestellt gewesen.
He was dependent on the help of the family, naturally. And what is with the pain? Was ist mit den Schmerzen?
Die Schmerzen, ja, die habe ich eigentlich ganz gut ausgehalten. Nur die Entnahme aus dem Beckenkamm, der Knochen nach hier, das war, glaube ich, das Schlimmste, was ich erlebt habe.
She said the surgery side pain is one thing, but the pelvic iliacal crest graft is a much greater problem, is for many people. Viele Patienten haben dieses
Das
Problem.
Schlimmste. Also die Kinder kriegen wir dagegen Kindergeburtstag.
Okay. Was ist im Moment, wie kommen Sie im Moment zurecht? What is the life at this moment? We have the better time now.
Ich habe keine Schmerzen.
No pain?
Ich gehe Vollzeit arbeiten.
The work is okay?
Ich fahre Fahrrad, ich versorge unsere Tiere.
Bicycle drive?
Ja, wir haben Pferde, Katzen, Hunde, das kann ich alles versorgen.
Horse riding, okay. Sport is okay. She is very active. And it is naturally, we have a good condition in her case, but she is so active and she have the opportunity to make sport, help her family, and all social things that a patient need for the treatment. Sie haben alles gehabt, was sie brauchten für diese Heilung.
Ja, und ohne meine Familie oder unsere Mädchen hätte ich es nicht geschafft.
Were you in this time very sad? Waren Sie sehr traurig in der Zeit?
Ja, ich habe auch manchmal da oben im Zimmer gelegen und musste dann schon mal eine Träne vergießen. Ne?
And sometimes alone must cry, yes. And that is a hard time for her, yes. And that was a complicated case, but not the most complicated case of the world. Yeah, I think she has the ability and the will to continue with the activities that she had. Was ist mit jetzt im Moment? Machen Sie sich Sorgen, dass das wiederkommt? The question is whether she's afraid of the continue of the osteomyelitis or recoming of osteomyelitis, recidivum of osteomyelitis. Haben Sie Angst, dass das wiederkommt?
Nein, glaube ich nicht.
Okay, yes. The time is long, 2 years is okay, yeah, okay. Thank you very much.
Gerne.
Dankeschön, es ist fantastisch, wenn Sie die Leute auch hören, weil wir erzählen nochmal. Mr. Scholar, Herr Scholar, vielen Dank, dass Sie gekommen sind. Ich finde fantastisch, Sie sind auch verletzt gewesen, krank gewesen, lange Zeit, long time for the treatment with Ilizarov and removement and weight bearing. Wie war es bei Ihnen, ja, als Sie gehört haben, as he heard, von dieser Osteomyelitis, von dieser Infektion, from this osteomyelitis? How was this comment from us? You have an osteomyelitis, we have removed the plate. Sie haben eine Infektion, wir müssen die Platte entfernen. Wie haben Sie gefühlt? Welches Gefühl hatten Sie in der Zeit? In dem Moment?
In dem Moment ist alles in Ordnung. Und, aber schwierig für mich, es steht zwei Monate im Krankenhaus und danach wann rausgehen zum Sozial, zum alle sehr schwierig mit Ringfixator, auch schwierig.
Was war, he said, everything is difficult, ring fixator is difficult, the family is difficult. Was war bei Ilizarov besonders schwierig, abgesehen davon, dass er stört? Natürlich ist nicht schön. Was war besonders schwierig? Ist das schwierig? Man kommt gegen das andere Bein. What were the problems with fixator, ring fixator for you?
Der Ringfixator, alles in Ordnung. Wenn meine Kopf gemacht ist, ich bin sicher und habe ich keine noch mehr Unfall passiert. Und danach psychologische gemacht, sehr gut, nichts.
Aber kamen Sie mit dem Fixator zurecht? War es okay in der Zeit?
Ja,
long time?
Sehr gut.
Okay.
Sehr
Haben
gut.
Sie Schmerzen gehabt? Whether he had pains during the fixator, Ilizarov fixator? Haben Sie Schmerzen gehabt während dieser Zeit?
Habe ich ein bisschen Schmerzen gehabt, ungefähr 30%. Aber
30% of the initial pains remains during the treatment with Ilizarov. Die Frage ist, wer hat diesen Fixator gereinigt? What is with the care of the fixator? Nurses or the mother or the sister or
himself? Ich habe Glück gehabt, meine Frau zu Hause selber
The
gemacht.
wife,
Ja,
yes, the take care. Okay.
jeden Tag sauber gemacht. Und,
The bandage und alles.
ja,
Okay. Disinfection.
und
Okay.
absolut Glück
Okay.
mit
Okay. Now, jetzt, the ring fixator is removed, der Ring ist weg, ja. What was the feeling? Was war das Gefühl? Wie ist das Gefühl? Oder war direkt nach der Entfernung, wenn Sie, das ist schon noch after the 5-6 months after the removal of ring fixator, what was the feeling? Was war das Gefühl, als es wegkam? War nackt, war leicht?
Wann weg gemacht und die Beine sehr leicht und will nur so zocken.
He said he has any coordination for the legs. He had the feeling that the leg is very lighter than the old time. Yeah. Okay.
Und danach langsam nach einer Woche will probieren zu Hause ohne nur direkt am Boden lassen. Und die Nerven, die alle hier aktivieren. Ich 10 Monate gar nichts, lassen die Beine am Boden. Steht die Fixator hier und danach langsam, jetzt steht in meine Kopf.
Die Propriozeption
Ja.
is the nerve ending here and weight bearing. That's a problem ist schwierig in der Anfangszeit. Das ist richtig, ja. Weight bearing after a long time is very difficult, ja. And how is now with the pain? Wie ist es mit den Schmerzen im Moment?
Jetzt die Schmerzen ist vorbei. Nur wann laufen mehr am halbe Stunde oder eine Stunde, danach kommt größer geworden und muss danach
Schwellung, ja.
ein bisschen relax lassen.
Okay.
Aber ist alles in Ordnung.
The initial swelling after removal of fixator extern ist aber normal, ist normal, es geht besser. Okay, thank you. I think, do you have any questions or guests or no? Carlo.
Do you work or not? Do you work?
Yeah.
From a financial part, from the working aspects, what is the impact of having this type of complication?
Wie haben Sie finanziell sich über Wasser gehalten?
Ja.
Während der Zeit. Also in der Zeit, wo Sie krank sind, arbeitet man nicht, richtig? Wie haben Sie Geld verdient in der Zeit? Wie haben Sie gemacht?
Ich habe Glück gehabt. Ich bin Kranfahrer. Am ganzen Leben nur aktiv. Ich bin 50 Jahre alt. Und ganzes Leben nur aktiv. Jetzt ist der erste Unfall in meinem Leben. Und habe ich Glück, ein bisschen Geld gespart. Und das auch Glück für mich, die Kopf nicht kaputt gemacht. Man hat keine Geld. Man hat, kommt alle und danach ist es schwierig für die psychologische. Das ist.
They said he has the whole of the time in his life. He worked very hard, year for year, as driver, and long distances, and gained good, money. And from this money, could live a life for this time. But for him, for the financial aspect, not so dramatic in this time. The psychological aspect was for the catastrophic.
Thank you. I'd like to ask about the smoking, nicotine. All my cases with infection or osteomyelitis, I give them instruction to stop smoking as a condition to start operating him. What about smoking, nicotine, about the infection, union, delayed union, and late infection later on?
I think I understand the question. I ask her what I said to her at this time about nicotine. Er fragt über Nikotin. He understands it, ja. Er sagt, wir müssen behandeln, wir müssen aufhören mit dem Rauchen. Was haben Sie gemacht, als ich gesagt habe? I said, please don't smoke, ja, Frau Voss. What did you do? Was haben Sie gemacht?
Ja, ich habe versucht, es ein bisschen runterzuschrauben, aber Sie haben mir ja jeden Tag aufs Neue erklärt.
She said, yeah. Mr. Tisval said to me, every day and every hour, don't smoke, but she had tried to go away from a cigarette, but not 100% for her. Was okay. The most of the people with smoking, they can remove it immediately. But it's important that the next day and next week, step by step, go down. Yes, das ist. Rauchen Sie? Okay. Frage, rauchen ich Sie? Wie haben Sie das gemacht? Wir haben
Yeah, I see him smoking outside. And there is the brace. Yeah, what is the...
Ja, war nicht rauchen. Beispiel, so steht in meine nichts merken die Schmerzen. Das steht in meinem Kopf.
Dann erstmal eine rauchen.
Ja, und danach rauchen. Aber ungefähr.
He said, in the case of the pains, for him was the solution to smoke a cigarette. That is to solve their problem. The pain too. Yes, the cigarette is the solution for financial problem. Is a solution for wife problem. Is a solution for pain problem. Yes.
I lost my union, but I don't lose my mind. Yes.
Yes.
Ja. Jetzt fast 10 Monate waren krank.
Ja.
Aber habe ich gesagt, will die Schmerztablette nichts nehmen. Und die alle.
Was ist mit Rauchen jetzt? Was ist mit Rauchen jetzt, Herr Skala?
Die elektrische.
Okay, he change the cigarette to electric. I think electric cigarette is more difficult than the normal cigarette. More smoke for the people too. Yes. Yes. But for him, it's a solution. Yeah, it's really okay. Another questions. Yeah. Okay.
Auch am Zigaretten habe ich fast 10 Jahre war nichts mehr rauchen, die normale Zigarette.
Ach so.
Habe ich die letzten 2-3 Jahre einmal probiert, die normale Zigarette, und danach muss gehen zum
The change to the electrical cigarette was before the accident on the osteomyelitis, he said. But
it's all about nicotine, not smoke or nicotine, electric or not. It's nicotine.
Also er meinte, war das eine Dampfzigarette, aber ohne Nikotin. Ohne Nikotin, ja, without nicotine. He said, yeah. Okay, thank you. Another question? I said, thank you very, very, very much for your coming. Danke, dass Sie gekommen sind, Frau Voss. Herr Skala, vielen herzlichen Dank mit Ihrer Krankheit. I'm very happy about your success till now. Ich bin froh für den Erfolg bis jetzt. Sie haben sehr viel Geduld gezeigt, ja, sehr viel Geduld und Power und Kraft. Und ich hoffe, dass es nie wieder kommt. Ja? I don't wish any recipe, please. Yes? Okay. Thank you very much. And have a good time. Vielen Dank, Frau Voss. Ja, gute Heimwahl von Ihnen. Ich danke Ihnen herzlich, dass Sie gekommen sind. Dankeschön. Ja, danke. Herr Skollert, machen Sie es gut. Bitte nicht fallen.
Ich will auch Danke sagen und will danke für die Herr Oliver und für die ganze Team am Unfallchirurgie.
Thank you very much. He thanks the staff. Thank you, Herr Skollert. Please be careful. Please be careful. Thank you. Thank you very much. Yeah. So, I think, dear Cengiz, you want? Yes, please. René, ist auch, beide sind an. Okay. Beide sind.
dear moderators, dear colleagues. No theory is available unless its postulates are translated into concrete recommendations. Therefore, in this presentation, we will detail the preventive measures have developed based on our proposed theory of the origin of PGI and FRI. PGI FRI relative rare, but each case is very expensive. Treating PGI costs several times more than uncomplicated primary arthroplasty and places its heavy financial burden on hospitals and healthcare system. Projected costs are expected to increase approximately fourfold. This estimate excludes additional future expenses such as insurance payout, outpatient care, and indirect costs. In Germany, this corresponds to an incidence of PGI at 6 to 12 per 100,000 inhabitants, which amount to an absolute number of approximately 5 to 10,000 patients with PGI annually. I have nothing more to add of these data, dear colleagues. Orthopedic and trauma surgeons generally agree that it is far better to prevent infection early than to treat it later. There are many different protocols to preventing infection complication in surgery, but they all share a common structure, a three-step approach to preventive measures. And we adhere to same principles. Let us first consider preoperative prevention measure in the context of our proposed pathogenesis of infection complication. These measures combine previously developed interventions with a number of additional recommendations. The key elements of ERA's programs are aimed at attenuating the psychology response to surgical stress. They're facilitating to more rapid return to baseline. Evidence suggested that ERAS not only improves clinical outcomes and quality of care, but also provide significant cost savings. Supplementing ERAS with the measure we proposed aimed at limiting lipid peroxidation, targeting mechanisms of microbial translocation, may further mitigate the determined effects of surgical stress on the body. Patients' active participation in their care is critical to surgical and rehabilitation outcomes. In clinical, engaged patient as partners is recovery. The patient's own motivation and mental energy will support healing like placebo-related effects. In the battle against disease, there are always three participants: the patient, the physician, and the illness. The outcome depends on whose side the patient chose, saying Avicenna. Postoperative insulin resistance is well documented and can be mitigated in elective surgery by specific perioperative measurements such as preoperative carbohydrate loading, epidural analgesia, and so on. This conclusion that the authors aligns fully with the concept we have proposed regarding the pathogenesis of the infection process in PGI and FRI. Investigate the link between the gut microbiota and the risk of periprosthetic joint infection will enhance our understanding the pathophysiology underwent the development of PGI. It's evident that microbiome studies such as sequencing or short chain fatty acid analysis will need to be integrated in the surgical practice. Furthermore, research is required to develop preoperative strategies for correcting the patient microbiome. Preoperative correction of anemia is a means of preventing postoperative tissue hypoxia, has long been recognized and is widely employed in cardiology and other surgical disciplines prior to elective surgical interventions. Antibiotic prevention of PGI and FRI. These data remind us that also preparative antibiotic prophylaxis is widely used. It is not sufficient on its own. It cannot neutralize the pathogenic factors such as stress-induced necrosis, microcirculatory valvular, and subsequent bacteria translocation. This film is an allegory about antibiotic use. It shows how identifying one or two pathogenic and then targeting them with antibiotics can disrupt the hydrates of the microbial species that make up the microbiome and consequently affects the patient as well. This film created by our friend Professor Augustin Telesa. Please stand up. Thank you very much. But this is no sound. This is no sound, sorry. Sound. This is no sound, excuse me. But you see, understand, and we know what about is. This is like microbiology laboratory. And this is antibiotic therapy. And lake is the stomach. This is our colon after antibiotic therapy. The use of antioxidant is not yet part of standard preoperative protocols. This therapy requires controlled clinical trials of orthopedic patients. Our study conducted in the 1990s demonstrated that antioxidant therapy of acute and recurrent osteomyelitis significantly improves treatment outcomes. Intraoperative asepsis and antisepsis. There is 7 features. And antisepsis remains subject of ongoing refinement. Here we have added just a few additional nuances to standard practice. They are. In my first dissertation work from 1918 to 1984, we studied intraoperative surgical wound contamination. We performed microbiological analysis to swabs from the wound every 3 minutes during the procedure. The results showed that the number of positive culture increased with surgical time. This finding has since been confirmed by numerous studies and is now generally accepted. Therefore, washing the wound before closing, it is necessary procedure. This gnatobiological technique is very simple and was originally developed for transferring materials through an antiseptic bath into an gnatobiologic isolator. We have adapted it for intraoperative use so that any instrument that has been in contact with the wound returns to the stable table only after passing through an aseptic solution. This minimizes the risk of secondary contamination of the instrument table, except with operation in the infection wound. It is a very moment. Adipose tissue remains exposite. Adipose tissue remains exposed for a longer duration than any other tissue during surgical intervention. It is the first to be incised and the last to be sutured, rendering it highly susceptible to contamination. Furthermore, this specific tissue is most frequently and for the longest period subjected to compression by retractors, which increases the risk of developing local ischemia and necrosis. And it must be incised before closed wound. Lipid peroxidation damage cell membranes in bone marrow, osteocytes, and soft tissue promotes cell necrosis and amplifies local inflammation. These necrosis and this necrotic oxidative modified tissue may then become preferable targets for bacterial colonization via translocation from the colon. Therefore, antioxidant supplementation should continue into the postoperative period. And this was postoperative prophylaxis of PGI. There is 7 subjects. Correction of microcirculatory disturbance after arthroplasty and osteosynthesis. Optimizing microcirculation in the early postoperative period is critical component of infection prevention. Better tissue perfusion, less necrosis, favor targets of hematogenous bacterial colonization. On the basis of these studies, the authors continuously conclude that probiotic prophylaxis should be regarded only as an adjunct to standard antibiotic therapy and not as substitute for it. The aim of such therapy is to help limit translocation of opportunistic bacteria into the wound. However, it is clear that any fear of reducing or modifying antibiotic prophylaxis will only diminish after appropriate clinical trials have been conducted. Adjunctive use of proteolytic enzymes can enhance enzymatic lysis and clearance of damaged cells, with the aim of reduce the nutrient base of invading microorganisms, and they have proven effective in the treatment of infected wounds. Dear friend, we propose that this infection prevention protocol for arthroplasty and osteosynthesis be reviewed by expert consensus and tested in prospective clinical trials, particularly in high-risk orthopedic patients. At the same time, it's unrealistic to expect surgeons to continuously monitor and manage the full spectrum of physiological and pathophysiological change after surgery. Therefore, we recommended establishing a dedicated specialist, for example, a perioperative medicine of infection prevention coordinator within orthopedic departments to assume these responsibilities, like orthoplastic team. As we have seen, this presentation contains many new and controversial ideas that must ultimately be tested and confirmed in clinical studies. Here I have tested only a few possible research directions. Knowledge is never sufficient, and the next steps now lie with you, the younger generation of research. Thank you very much.
Thank you very much, dear Cengiz. We have in this last session two colleagues from Russia, but I think I heard they had not the possibility to get a visa. Mr. Podkozov, Professor Podkozov, and Professor Nabachikov, yeah, both. I'm sorry about it, but we make the next presentation with diese Moro? Habe ich schon. Okay. Genau. For the colleague, for Professor Maro from Nagasaki, yeah, and he has the possibility to replace one of the absent lectures. Thank you very much. Yeah.
Hello, this is Akihiro Maro from Japan. I'm great honored to have a chance to present this meeting, and I want to introduce CRAP technique. Is a very common in Japan, but it's not common in Europe and other countries. And I want to talk about complication management in infected non-union treated with Ilizarov, not instead of Ilizarov to the CRAP technique. Okay, so my disclosure below. I'm from Himeji, is very close to Osaka, the western part of Japan, and I'm working with like a trauma center. I'm a trauma surgeon, and the last year in Yokohama, WAIOT is held in Yokohama, and I met Barry, and he is so interested in my technique, and he came to Japan, and I met him with Himeji Castle, is one of the biggest castle in Japan, and I invited him to the home party, and he had a lecture to my hospital. So now the surgeon, once biofilm is formed, the game is over. And we always fight with infection, but we can't beat them. But now I want to introduce CRAP, continuous local antibiotic perfusion. Okay, so it's a similar technique about the suction irrigation technique, like maybe 1970, but it's not the same. That concept is low volume, high dose antibiotics is perfused to the infection site, may prevent the infection. So the concentration is very important. If the concentration is very low, the anti-MRSA or antimicrobial is survived. But over the MPC, the prevention of mutant prevention concentration, the MRSA were killed by the high concentration of antibiotics as well as biofilm. So we try to keep this concentration by the local antibiotics. So one is IMAP, intermediary antibiotic perfusion, to use a special needle to put the antibiotic to the intermediary, as well as use the ISAP, inter-soft tissue antibiotic perfusion. I use a double lumen tube to infuse the antibiotic to the soft tissue, as well as aspirate the main tube by MPWT system. And then to combine the IMAP and the ISAP, so put the 2 pins beside the infection site, and then place the tubes and the deep tissues and cut and connect by connector. And from the IMAP pin by aspirate by MPWT, as well as put the ISAP tubes aspirated by MPWT. So the hematoma is replaced by antibiotics. So the deep tissue are aspirated by these tubes. Then hematoma is rapidly reduced. This is a CRAP system. Okay. So fracture-related infection. Once biofilm is matured, we can't retain the implant. We have to remove the implant. But by CRAP technique, just this May published by BJJ. According to the CRAP technique, we reduce the reoperation rate and also we reduce the recurrence rate. And the acute kidney injury is the same. So CRAP may say the effective and safe drug delivery system for the FRI. Now, according to the CRAP technique, if the bone union is completed, we remove the implant. And if the bone union is not completed, we try to retain the implant. As well as if the implant is improper or fracture is not correctly reduced, we have to correct the fixation. Or if I try to exchange the implant, one stage exchange, not 2 stage. Okay. So retain or sustain the implant. Last year I showed these cases, and the fracture is not incomplete. I try to retain the implant. So at 70 years old, female hit by car, and he got the lower leg open fracture. And after 3 days, I am really inserted. But unfortunately, after 18 days, CRP and fever is elevated over 38. Then the fracture is not union, absolutely. And then I try to retain the implant. So I put 2 pins in this area and this area. And antibiotics is infused to the medullary canal, and the antibiotic solution is spread to the soft tissues, and these solutions are aspirated by NPWT system. So after 2 weeks application, the infection is all gone, and she returned to work after 3 months. Okay, so one stage exchange is very important, but I want to show you the complicated cases. This 40 years male got the open fracture at the tibia for the Pharma hospital. and he put the X-fix and exchange IM nail after 1 month. Unfortunately, he got infected at that hospital. He tried to retain the implant by Knapp technique, but it doesn't work. And then they tried to X-fix, and then after 12 months, they changed to the plate. But the fistula is remained, and the pussy is overdrained. And after 4 years, pussy is not healed. And then, after that, he transferred to my hospital. So, this absolutely here infection is not healed, and bone thinning is accumulated on the mid shaft of the tibia, and this is daily amount of pus. So we think about the surgical plan. According to the bone scan, we have to remove all infected area and usually use bone translation. But instead of this technique, to use a Knapp technique, we try to put the antibiotics in this area instead of remove all bones. So first I make a hole by limbing, and then after that I put the IMAP pin around that, and then aspirate by tubes to circulate the whole infected area. And after that, I put the intermediate nail. And then before the intermediate nail, I put the multiple pinning to the infected area. And then I put another saline to wash out from inside to outside. So you can see the saline is washing out from the multiple pinning. So after that, I put beta TCP and bone graft from an iliac crest instead of the PMMA. So I think this material may contain the antibiotics better than the PMMA. So after the surgery, maybe 4 or 3 days ago, after he can walk like that. And then this is CRP level. CRP level is getting decreased after 2 weeks, and bone wound is healed. And I think it's almost 8 months after surgery, is no recurrence. This is examples. Last year I showed these series. So my opinion is, in combination with Knapp, we have to retain the implant or correct the fixation on implant or exchange implant. Anyway, I try to retain or sustain the implant. It's the best way to beat the infection. So my conclusion is Knapp enables to sustainable implant management by FRI, supporting local infection control during implant retention, exchange, and new implantation. The goal of the FRI is not complete eradication, but fracture union under control infection is more important. After union is completed, we can remove the implant. So it's much easier to eradicate the infection. So I would say that once biofilm forms, the game is just started by Knapp. So may change the Knapp may change the game, I guess. Thank you very much.
So we can discuss later. Thank you. Thank you very much, Professor Varro. We have to continue with Ms. Is correct. Yes, is correct. And Ms. Henke about AMR, how to control in orthopedic surgery, is correct, yes? Okay, please, stage is yours.
Alles gut. Hello again. Doesn't work? Yeah, works. AMR, we all know this. We all heard about that. And that is what I said already in the morning. Awareness is not enough. Because everybody is talking, and that is the same if anybody comes from the press to us to say, would you like to say something? Then I say, to be honest, you need to find another headline, because antimicrobial resistance, the threat of the world, you can't reach the people anymore. You have to find any other fancy words for that. I don't have any fancy words here at the moment neither, just to give you a little bit repeat of that and where it comes from. European Commission has a wording for that. The WHO has a wording, is quite similar in that, but the threat of antimicrobial resistance, it's clear. It costs money to us all. All the people, and you heard in the word millions time already as well, the silent pandemic and an end. And if anybody from the media talks to us, I always say the biggest problem with AMR, it doesn't hurt. Because you don't know if the strain, what you have, the bacteria is resistant, yes or no. You don't know anything about your neighbors, you don't feel it, you think everything is fine. But the biggest problem, and all the people they are thinking about, that is just the development of antibiotics. Because all the people, they say, hey, super simple, and the industry, they will make it, they find another antibiotic, and that works. But if you look at that, how fast antibiotics today are resistant against any bacteria, and if you think about now, coming from the company perspective, how long it takes to develop an antibiotic. They are 8 years, 10 years, 12 years is normal with all the clinical trials you have to do, and after 1 year, you have a resistance, you can't earn the money. So the interest of the industry to develop new antibiotics is, not the highest one. Then just to come back to that, to say, industry must do, and they must have to do anything, research, that they have to find any solution in that. Then they come with problem with Germany, for example, they say, if you have the next antibiotic, you get 7 years, you're the only one. And I say, is that the right way? I think not, because then you stop any innovation for the next 7 years if there's only one product on the market which you can use, and maybe that is resistance as well. And so it's not so easy to deal with that. Next problem we have, WHO, glass system, they have a surveillance system with all the data in all the countries, they deliver the data, and you know these all, what they have with the system, which bacteria are the most critical one. They, every 2 years, they have a new list of bacteria which are now resistant. You have an understanding of the world map, but they are historical data. They are not up to date. They are from the last 2 years or the last year. What are you doing in your hospital? If you get the data from anywhere in the past, you can't do anything about that. So what is missing at the moment in most of the countries is a proper alert system. So if anybody sees, or you send the data to your biologist, and they see, there is not a green light anymore, maybe it comes to yellow, then you have a chance to react. But not if anybody tells you in 2 years, you had a problem there. Super, too late. Nonetheless, we have these reports it's organized by the WHO in all the countries, and that is a system for Asia. It's called CSER. It is nice to get an understanding where we are and where are the reporting system. Nonetheless, we should do a little bit more out of the data. As long as it's just published data, it's not good enough. Coming back to orthopedic surgery, there's a recent publication in there saying what is antimicrobial resistance in orthopedic surgery, and you see there on the side it is clearly same problem as we have in all the other areas as well. Oh no, that is the ICU. Now it comes to the orthopedic surgery. I think the line there on the left from the graphs, a yellow one, there's revision surgeries and with resistant strains. The problem we have today is we know the cost, and that we had on the slides before, 25,000 roughly for a surgical site infection. We have data for infection in orthopedic surgery, but we don't have any data. What does it cost additionally if you have a resistant strain in your infection? There are no data at all over the world. I looked for that millions of times to say, tell me, what does it cost? Yeah, you have these, in 2050 it cost you whatever. Nobody knows the database behind. We don't have any proper data. So if anybody of you would like to find some health economic data, that would be a support for everybody, because then we can use that in a better way. Another system, what lots of people don't have in mind as well, the DDD graph there, defined daily dose. It was designed by the WHO as well, just to compare the consumption of antibiotics all over the world. And you see, some countries are using a lot of antibiotics. Germany is pretty low. We are not on the list there because we are too low. But there are some countries where have a super, super high consumption of antibiotics. If that's right or wrong, at first it's just a number in there, and then you can think about what you can do with that. Coming to say what is then new, what can we do as a method to combat or fight against antimicrobial resistance, what is new on the market? What you always have is these active peptide components, these small molecule antibiotics. Do you know what that costs? Much, much more. Do you know what you have at the moment on antibiotics? Is peanuts. It costs nothing. And now all the people say, go to the pharmaceutical industry and support the pharmaceutical industry that they can develop these antibiotics. I personally think, yes, they should do it, but it's not the only solution what we have. We should do something else. Microphage therapy, it's not there. You can have a personal opinion about that. In Georgia is pretty strong in that. For me personally, I would use it as a last option, because it's more, for me, a little bit try and error. You don't have any clinical data in that so far. Maybe anybody develops something. I personally, it's something as a final stage if you don't have anything. So, bioceramics, they mostly use antibiotics in. So then, it might be better than a purely antibiotics, but finally it's antibiotics in. Metal-based material or silver. We have lots of resistance against silver right now. I don't know if you have a little bit heard about the FDA, what they did right now in the US. They had a long list for in wound care, what they say wound dressing, and they would like to sort it out by risk of AMR, to say, okay, here you should at first use a product with the lowest risk. From silver, we knows it, or the industry knows it as well, so it's at the moment a little bit on the list, or the people they try to find something just to avoid silver. And the simple thing what you can say is, if you go to in this area here with all the mines, now not charcoal, now silver mines, you find bacteria in there, and living bacteria, they are resistant. So that is a little bit the problem with this material, with the metal material. You can say, hi, we have copper, but you will have the same problem with copper if you use it in the same amount you use silver right now. So polymers, we heard a little bit about that already today. That is something I personally think it's super, super promising. Because they can bind material, they can deliver products, and. I think that will be part of the future, but, and that is a little bit the problem right now, we are at the early stage. We are not there where we should be today, or where we wish to be, so, but that is definitely an area which will grow. DAC technology, and that is what I said before as well, finding something with a low risk, which is already on the market, because that is a problem what we have. We can say, we always look into the future, and maybe at any time we will have, but taking a product from today, from the development to the market, takes medical devices, minimum 7 years, 8 years, pharmaceuticals even longer. So we have to find something in between. We have to find a solution, what we can do today and now and not tomorrow. There's lots what's going on in diagnostics right now. I think that is an area as well where we should be a little bit more, I don't want to say creative, a little bit more open to use that. That is a question of the reimbursement system. We have to convince the governments to pay for that, because it can't go only on the cost for a hospital or to the doctor. It must be paid, so we will support. Another area clearly is artificial intelligence. There are lots of systems right now to predict something, which is definitely the right way as well. But you see, there is something on the list, but it's not the super game changer. We have to do it a little bit more. If you think about, and that is, I would like to give you a little bit an example for that. With all these technologies, just in wound care, just basics. Randomized clinical trials is one. And all the people, they come, yeah, show me your RCT, and what is your evidence level, and. I always go back and say, okay, going one step back and say, what is a risk profile? And that's the same what the FDA is doing. What is the risk profile of a product? And think about that first. For all your products, you have an IFU, you have information for use. There's lots of information in what you can use. And just to combine something like silver dressing, PHBM, UDI, DACC, and just with 4 criteria, mode of action. What happens there? That is a noun, that is clearly clear what is going on there. So DACC, for example, that is hydrophobic binding. Have you tried to understand what is hydrophobic binding? You see it every morning going to the shower, because that is a mold what you have in a silicon, and that is hydrophobic binding, which you can't get out. It's so strong that you can try to clean it, you don't get it out. So that is hydrophobic binding. If you go to the precautions, there are lots of information in the current information for use. what you can use with side effects. Then you have a limitation, which is in the IFU as well. Where are you allowed to use this product? So lots of things already. Then endotoxin. Yeah? At the moment you kill a bacteria, you have an endotoxin release out of the bacteria, which provide problems as well. So just simple basic, you can find something out of that as well. Coming a little bit to this awareness piece, what can you do? For me, it's a multifactorial problem here, or there are elements where you definitely can do something, and I list here some question about that, what you can do and what you can't do. Finally, if you think about all these questions, discuss it with your team. Are we there? Are we not there? For me personally, we have from the WHO, this One Health strategy, and every country has a national action plan to fight against antimicrobial resistance. Is that enough? I'll just give you an example from Germany. I talked to one of our health senators from one of these states, and I don't say which state it was, and I don't say the name, because I asked him, what is about our national action plan? What are you doing in your state, in your office? He said, I'm so sorry, I don't know. I have to go back and ask. So any governments, they're doing something, yeah, but it's not worth the paper it's written on as long as it's not on the base. So if nobody lives that, what is in these national plans, yeah, then it's nothing. So here are a list of questions, and I don't know if you share the presentation, just to think about what can you do, if that's something, what is in. And therefore, I would like to save a little bit time here. They were always a bit faster. It's a growing set. I guess nobody has any doubts in that. Prevention, we heard this all the time, is one of the most important things. If you don't have any infection, you don't have to treat it. Antimicrobial stewardship is important. All the plans you have in your hospital, and I don't mean the National Action Plan, I mean your plan in your hospital. That is much, much more important because it's adapted to your situation, what you have. And it's a multi-sectoral problem where you have to talk to all the people. And now I saved 5 minutes.
Thank you. So dear friends, you have only 2 lectures remain. The next lecture is of General Secretary of WAIOT, Carlo Romano. Carlo, please.
Okay, so in this presentation I will touch a little bit some new fields that can be quite, I think, interesting. The title is New Technologies in Artificial Intelligence, Robotics and Antibiofilm, but for time restrictions, I will focus only on artificial intelligence applications in musculoskeletal infections. This is also published in Journal of Arthroplasty. This is a combined effort, was published last year. As you will see, many of the papers that I will cite today have been published in the last 2 or 3 years. So we are talking to a very brand new field of application and of research. Artificial intelligence has many different subsystems. In particular, one of these that has found a big application in medicine is machine learning, which is based on pattern recognition and learning theory. There are different applications of machine learning, but the principle is to apply algorithms to study large data sets, and this allow the computer to make projections and to identify relationships that are not immediately visible to humans. If well used, it has been shown to be this technology to be superior to the expert opinion and to what humans can understand and can create by themselves. There are different fields of application for this technology. It can be applied to diagnosis, to make predictions, to find new treatments, and I think there is another talk from Dr. Augustin after my presentation, and it can also be applied to consultation and to education. What about diagnosis? And this is a very first application that was published 3 years ago from a group from Milan, in which the idea was to apply artificial intelligence to differentiate septic from aseptic loosening of joint prosthesis. They included 173 patients, which can be a large number, but for the best performance of machine learning is not so high, this number, we will see later. But in any case, they could find that the program was able to differentiate aseptic from aseptic loosening of a joint prosthesis, of hip prosthesis, with a very high sensitivity. But the specificity remained quite low. If we increase the number of samples that we can give to the machine, the results are much, much superior. This is a very interesting paper published last year. It's a combined paper published from Zimmer Biomet and from the group of Philadelphia, in which they could include synovial fluid biomarkers. They collect in a centralized lab in the United States from around 3,000 institutions, more than 130,000 samples. So with these very large data sets, they could really show the power of this technology. If we look at the results, it is possible with this technology to make the diagnosis of periprosthetic joint infection only using synovial fluid biomarkers with a sensitivity of 98% and a specificity of 97%. So this is a striking result, only using synovial fluid biomarkers and no microbiological data. And the diagnosis can be done within 24 hours. These are the biomarkers that were used. Not all are available on the market yet, but this is a panel of biomarkers that, used in combination, may significantly increase the diagnostic ability. Another interesting application is to see how these language models are able to solve clinical cases related to musculoskeletal infections. And this was also published last year, in which 15 different large language models were trained to solve different cases of osteoarticular infection using the published guidelines. And what it turns out is that the best performance was obtained by two of these models, that is Microsoft Copilot Open Evidence and ChatGPT and Gemini, that were able to correctly diagnose osteoarticular infection in more than 90% of the cases. This is the performance of the different systems. The worst one were able to make the diagnosis in 84%, the correct diagnosis in 84% of the cases, but the best one were up to 94%. Another application is prediction. These language models can make predictions starting from different possible risk factors of our patients. And this is an application of the risk to the risk of infection in patients undergoing osteosynthesis of the tibia. As you can see here, the number of patients is relatively low, only 350, and only 51 were infected. This is a cohort of patients that is quite low, and in fact, their application achieves good result, relatively good results, in that it was able to identify, to predict correctly the risk of infection with an area under the curve of 0.85%, which is not bad. We must remember that the best is 1, of course. 0.85 is a good result. But look at what happens if we increase the number of the patients. This is another paper published in lumbar spine surgery to predict infection. They included 1,327 patients. These were the different models, the language models, and the different risk factors that they included. And this is the area under the curve that was possible to achieve applying these models, 0.98. This means that you have nearly the ability to predict for every single patient if he or she will develop an infection. There are some risk factors that are more significant, but and only 5 of them are able to achieve an area under the curve of 0.85. And this is another interesting application in patients undergoing surgery for metastatic spinal disease. 667 patients. These authors, they used different models. The best performance achieved an area under the curve that was more than 0.95. But what is interesting is also that they compared this result with the opinion of 4 expert surgeons. And this is the result. The machine learning system achieved 0.98 area under the curve. The experts only 0.58, 0.06. This means like throwing a coin. So this compares the ability of these technologies to the human possibility of predicting correctly surgical site infection risk in the patients. This is another study in which in a large data set of 27,000 patients, it was shown that to predict the risk of infection after joint prosthesis, it can be obtained a very similar, very high prediction ability. This study was conducted in Romania, published recently, but what is striking is not only the result, but and the exceptional ability to predict periprosthetic joint infection, but also the timing. In less than 1 second, the machine can predict for every patient what is expected risk to develop an infection. This can have very important implication from many points of view, not only from the medical point of view, but also from the medico-legal point of view, and also maybe to personalize the type of prophylaxis. Another application of this technology is to treatment, especially to find new treatments. This is just one paper published this year in which it has been investigated the possibility to find new antibiofilm compounds by these systems. So they administered 45,000 possible peptides, and the model examined all these peptides, and he selected some of these compounds. When they tested these antibiofilm compounds against the best control that was available, it turns out that these compounds were at least 10 times better as antibiofilm than what we know today. A final application of artificial intelligence is consultation and education. We know many patients, they go and they search for, they ask to have news and to inform themselves about what is going on from the health point of view. So this study here in Germany investigated the ability of ChatGPT to answer correctly to the questions that can be posed by patients or even doctors. So they selected the 12 frequently asked questions from big institutions here in Germany, and they administered this to ChatGPT if looking if the answers were correct. And what it turns out is that there are no wrong answers. No one was a wrong answer. The majority was satisfactory answers, and what is interesting is that these answers were not only generally corrected and in line with the guidelines and the knowledge of today, but they were up to date. They were formulated in a way that is understandable, and this means that these tools can be a valuable help for our patients, for the patients in general, but also for the doctors. A last study that I want to show you is the application of ChatGPT to periprosthetic joint and knee infection to understand if this device is able to provide to answer in a correct way to complex questions about hip and knee periprosthetic joint infection. All the parameters, there were 27 questions and 3 independent raters, experts, that evaluated the answers from ChatGPT. What it turns out that the answers were considered as complete, up to date. They were considered useful both for patients and surgeons, not misleading, and without errors. So this means that we are still probably at the beginning of a big revolution, and WAIOT must know that this revolution is ongoing, and we must, in my opinion, try to be on the wave and use this revolution and favor this revolution in the right direction, as it is published recently in The Lancet. Thank you for your attention.
Thank you very much, dear Carlo. The last lecture from today is about artificial intelligence for our college. Agustin Teles Durante. Agustin, please. Yeah, it's a very interesting and new theme, and Agustin is very experienced, not only in the medicine, but also in the IT and in the session of artificial intelligence. Thank you.
Hi, good afternoon. So we're kind of tired, so I'll try to wrap it up in a way that you feel it good. In the first thing I want to say, I want to thank WAIOT for giving me this opportunity to be here and talk to you. I would like to congratulate Dr. Seval for the good organization of this event. It has been very high quality. So we're going to talk a little bit about the algorithmic lens of orthopedic infections. Dr. Romano already explained a lot, so I'm going to go a little bit faster. Here we have a graphic where you can see the traditional diagnostic success of infections in orthopedics by human beings, that's the line under it, and the success rate by AI that has been published up until this year and this month. So how is it working? In a nutshell, we can see that it analyzes the clinical text, all the files, all the lab results. You put it into the AI. When you take the synovial fluid, the markers, the results, you put it into your AI, and the x-rays or any radiologic evidence, you will have the AI analyze it, and it will give you a prediction, a diagnosis, and the surveillance you need for your patient. Okay, so here's the thing. This is a plate in the osteosynthesis of your patient, and that's the biofilm that we fear so much that happens. Why? Because it protects the bacteria against antibiotics, so they cannot get into to do their job. So that's where we use this tool by grasping the synovial fluid into the equation together with the files and the x-rays. Here we're going to find all the specific chemical markers that humanly it will take a long time for us to diagnose. Okay, so the AI can detect the differences between magnesium, potassium, chlorum in your blood, everything, the cell levels, and integrated form an algorithm to detect specific bacteria. You see, you don't have to wait until the culture is ready now. The AI will form these patterns for each bacteria depending on the chemical footprint the bacteria leaves on the synovial fluid. Together with the X-ray or MRI or CT scan that it analyzes, the patterns will fill up the gaps. So now you can have a better idea what to give the patient, and you don't have to wait all the time for the cultures to be ready. Okay, that's the first useful tool that we can find. Then all the information surrounding the patient, if it goes through your AI processor, when you have the files, the history, the different stuff that doctors have been putting into the medical chart, it will follow the patterns to find out how this works. You see, on Johns Hopkins, there was this study where they searched for the main cause of patients coming back into the hospital. Once they were discharged, what was the main lab to seek for so that the patients wouldn't come back, okay? And they found that this was the hemoglobin inside red blood cells, okay? That little data made the difference to prevent patients from being discharged and then readmitted. And that saves a lot of money and suffering to patients. Like the story about that doctor said that he found the patient while she was almost in her car. Well, here's a tool to prevent that kind of stuff. So the automating surveillance through natural language processors and transformers, the LLMs, they analyzed up until now in this meta-analysis 19,661 health care episodes, and 99.18 and 99.98 negative predictive value and sensitivity were given by the AI, versus the clinical chart review that was used before, that it was 88.95. So there's a big improvement. Traditional ICM criteria versus the AI meta-learner system, you can see here are the two differences. First, the static thresholds for single biomarkers in the traditional way, the limited sensitivity of low-grade infections. This does not account for dynamic biological interactions, because when a doctor sees the patient, he only sees a moment of the patient, while AI can follow the patient along. How? We have wearables. There are patches that you can put into your patient that will be monitoring the patient for 24 hours. And all of this info goes live through his cell phone into the AI and back to the doctor. So the patient might be on a trip and the doctor gets a notification from the AI that he needs to call the patient. Okay? So we assemble all this diagnostic superiority because the area under the curve, as Dr. Romano said, it was 0.98 in revision arthroplasty, outperforming the ICM techniques. Okay, the surgical timing on second stage prediction, the area under the curve was 0.96. Okay, so what can I say? The commercial translation via Syntition score, this will help also transitioning all the models that we are using right now to new models that will help predict better and make better diagnostics. The computer vision of deep fractures and extraction of this information in the HipNet. Okay, what is this? There's these models that in different countries and servers, they have been uploading all the x-rays that they've been getting from patients and making these large files, okay? So all of these are collected in seconds by the AI, and it gathers experience that a human being wouldn't be able to have even if he lived for 100 years, okay? And with this, it makes the patterns that will fill out the evidence it needs when it's looking into the x-rays and these systems. So, differentiating complex pathologies under data constraints will give us this result, okay? The AI will do a data screening, data pre-processing, deep learning, the accuracy of the results, the grade counts, and the interpretation by the physician, okay? This model was designed in a study where they were differentiating between acute osteomyelitis and Ewing sarcoma, which are kind of confusing. Maybe not for a very experienced surgeon, but for regular orthopedics they are. And AI here was state of the art. It didn't miss almost nothing. So let's go back to the biofilm. Because we're in WAIOT, this is an infection congress, we want to know how to AI is going to help us get rid of that. Okay. We already talked about the diagnosis. So here is the new technology. This is right out of the oven this year. Sound. Okay. You don't want to use antibiotics, but you need to go through that barrier. All right? So you need a physical element, something that can go into the body. So I'm an ultrasound specialist in Mexico, and sound can go through skin and through tissue, and we can fix certain frequencies so that when it reaches the spot you want, you can have a sweet spot of a frequency, okay, like music. So bacteria, if you give this sound to the bacteria, it makes micro bubbles inside of it. And the micro bubbles explode. So it kills the bacteria from the inside. Okay? But you gotta be careful, because if you don't give the right frequency, first, you won't kill it. And in second place, you might damage other tissues, right? Okay. So first step, you need a frequency that is specific for the bacteria and specific through the amount of tissue that the sound is going through. So these calculations are really mad. They're mathematical, and they have to be fast. So here you plug in the sound machine into the AI, and it makes the calculations right on the site, and maybe at the same speed you're moving your hand over the patient. So you are on one side killing the bacteria. Second, another frequency will make this biofilm permeable. It will shatter it. So that will let your own cells go into it to kill the bacteria, and it will let also other chemicals go through this biofilm. Are you with me? Okay. So this tool with the AI is it can really change the ball game, okay? When you're doing surgery, you wash the patient, you make your dibration, you take out tissues, but remember that the canceller bone on the microscopic level, it's porous. So bacteria may go into the structure of the bone, and water won't get there. Not even antibiotics may get there, because not even blood is getting there, but there's a bacteria there. So here, when you bring in the sound, you can get rid of those bacteria. So the time of the osteomyelitis disease will shorten, because now we have this tool that will take us further than where we could go before. So here's an example. You target, you put the machine, you deliver the sounds, but then you need to fix how deep it's going to go to keep the right frequency. So here's where the AI does its magic. So the disruption of the sound will shatter the dormant biofilms. The extraction of the microcalorimetry captures the pathogen and the biomarkers in the moment so that you can know what's happening with the bacteria. This is a chemical response too. So we have two different machines. Or maybe there's this study where they say that with the same ultrasound, you can measure what kind of biomarker is there. But that's going a little bit forward too. Okay, the AI decodes the information, it classifies it, and then it delivers the kill shot with the sound, eradicating the bacteria. This sounds beautiful, but as always, we have obstacles on the way, okay? So we have to overcome the external validation on the first place, the explainability, because maybe I think I understand that. I think I said it right, but maybe I didn't. So I hope you ask me at the end if you still have questions. And the workflow integration of this system. These are the three barriers that have to be overcome before we can go forward. The future of the arthroplasty is going to change the algorithm. Okay, so we're going to have the text analysis, the imaging analysis, the biomarker analysis, and the acoustics, the specific acoustics for each region of the body and microbiota of the body. So I want to thank you. I want to thank WAIOT. Once again, I congratulate you for this excellent course. I'm really excited to be here. And I want to invite all of you to our Congress in the Caribbean, which is going to happen on November 13 and 14 in Cozumel Island. Of course, we're going to have some WAIOT talks over there. And you're all welcome if you want to join us. And before I finish, I would like to add that if anybody is interested in having the resume, I made a summary of all the talks we had today, so it's ready online. If anybody wants it, just come close and I'll give you the email address. Okay, thank you.
Thank you very much. I would say it's very, with a great engagement. Thank you very much. He is a fantastic spine surgeon and fantastic IT and AI especially. Thank you very much for the interesting future imagination. Yes, dear colleagues, we have done it. The last point is, or two last points. The last point is that we have, after this session, immediately the session General Assembly for the WAIOT members, and we have to choose the next president, vice president, and such activities. Before it, I would like again invite you for 7:00 p.m. today evening in restaurant Bönte. You have on the desk the papers. I would be very happy to see you there. Thank you very much. And last, invitation from Professor Parisia from Buenos Aires, the chair for the Congress 2027. Walter. René.
Play again, please, with sound. Done. It's more beautiful than the video. Okay. Yeah.
See you in Buenos Aires for the 6th Annual WAIOT Congress. And let's celebrate WAIOT 10th anniversary together. Thank you for watching. See you soon.
Okay, friends, thanks for the opportunity to show the video. It's very funny, the video. Thanks for the opportunity to be here and the opportunity to invite you to next year in Buenos Aires. In September, Buenos Aires is a beautiful city. It's springtime. It's a place to have many opportunities, cultural opportunities, gastronomic opportunities, and I think it's a big opportunity to add the Latin American community to the WAIOT to continue to grow this beautiful society. Thank you very much.
Thank you.
Yes, the General Assembly. So, good. Thank you, my friends. So I think with the disposition of the President, we go directly to the General Assembly. Let me find the paper. General Assembly here. Qui ce l'ho. I have on my screen, but not on the general screen.